Derita, derita, derita. Stop. Okay. Up. Don't move. Asparagus.
Hey guys, what's up? It's Stephanie and welcome back to my channel. So in the video today, I'm going to be doing an end of rotation exam review video. Hopefully this video is helpful for you guys. Just a little bit about me real quick. I'm a second year PA student that finished all of my end of rotation exams. I finished all of them. I'm currently in my elective rotation. I am studying for my PANS, so hopefully me reviewing with you guys, this video is helpful for you guys and will also benefit me since I'm studying for my PANS. Also in the video, I'll give you guys some pearls, some mnemonics that I memorized that helped me for the exams, some high-yield information that I saw when I was doing the questions through the question banks or even on the exams, and some of the things that I saw that were very commonly asked also. And just to tell you guys about me real quick, I finished all of my end of rotation exams and I got A's on all of them except for my first one. My first one was my EOR, and when I first started taking my exam, I didn't know how to study for exams, for end of rotation exams specifically, because it was very different in comparison for during my didactic year. So I needed to accommodate my studying and change it up in comparison from my didactic year to my clinical year. Once I did that, I started getting A's on the rest of my end of rotation exams. And sometimes it's really hard with some of the rotations that you're doing, especially, for example, for surgery. I was in clinic sometimes from 6 a.m. to 12 a.m. all day, and I didn't have a lot of time to study. And when I did get off early, I was just exhausted and just wanted to sleep and catch up on my sleep. So I know certain exams will be harder, but hopefully these videos are helpful for you guys. And if I make any mistakes, please comment below. This is my first time doing these videos, and I'll try to be as precise as I can, but I know I'll probably make some mistakes, guys. And just real quick, basically how I study for the exams is that we had 5 weeks for every rotation. The first 3 weeks, I would go and learn all the information that was on the blueprint. So the blueprint, of course, for those of you who are familiar, is on the PAEA website. Basically, it'll give you a blueprint of the topics that are going to be on the exam. You'll have topics that are really broad, like acute abdomen. I mean, so many things can fall under that umbrella. So you'll have broad topics like that, and then you'll have specific ones like otitis media, otitis externa, etc. And then some of your EORs will be longer than others. And in regards to the blueprint, some of them are 5 pages, some of them are 2 pages, 3 pages. So it just depends. And also, so for the first 3 weeks, what I did is that I studied the information. I used PANS Prep Pearls. I used the Roche Review exam book. It's a great book. I really recommend it. I also used Smarty Pants. Smarty Pants usually will give you also blueprint, but will also give you information on what to study. So you can just study that and you should be fine. But I like to add extra stuff. I did osmosis flashcards. I did the flashcards every day from day 1 to day 30 every day to make sure that I knew the information. I didn't forget it by day 30 because sometimes you'll forget the information during that time. And then also I used the PA exam review, the PA end of rotation exam review book. That book is great. I really recommend it. It's awesome. So I also used that. And then the last 2 weeks, what I did is that I did a lot of questions, and I really recommend that. I used Roche Review. I love Roche Review for exam test questions. They're amazing. They even have their blog questions for family medicine, for internal medicine, etc. And they're very similar to the actual questions that you'll get on the PAE exam. So I really recommend Roche. I did a lot of questions the 2 last weeks. I also did Exam Master. I did Smarty Pants. And I also did UWorld. UWorld questions are a little bit harder, but I really recommend them. I know for family medicine I was doing them and I was getting very upset because I kept getting them wrong. And then I ended up taking the exam and I got a 91. So I know I have to attribute that score to UWorld because the questions I had were also very similar to my end of rotation exams, and they're higher level questions. So I really recommend those resources, like I said. And this is what really helped me out to prepare for my exams, end of rotation exams at the end of the rotation. Alright guys, so today I'm going to be starting with psychiatry. So hopefully, like I said, this video is helpful for you guys. I have to say that for my psychiatry rotation, it was a really busy rotation. Usually in PA school, for those of you who are in PA school, you know that usually your psychiatry rotation is known as psychation, right? Because it's a rotation where it's a very easy rotation. You know, some of my classmates would get off at 2, etc. But that wasn't the case for me. My rotation was really busy. I would go in at 8:30 and I would get off at 6 sometimes. And then on top of that, I had to do weekends. Not every weekend, but like every other weekend. And so it was a really, really busy rotation, but I thoroughly enjoyed it. I learned a lot in regards to the medications. I saw a lot of stuff that you read in textbooks that you wouldn't think that you saw in person. So I'll be discussing that also. And then on top of that, I got offered a job if you haven't seen my previous video. But yes, it was a great rotation and I loved it. So I love psychiatry. It's great. But I don't know if I want to pursue it, but I just thought it was very interesting. Alright guys, so let's start with psychiatry. So I'm going to start with major depressive disorder. The thing about psychiatry is that book-wise and textbook-wise, and according to the DSM-5, which is what a lot of psychiatrists use, a certain disorder is diagnosed on a timeline. So whether it's been this long, this long, this long. So this is what you have to know for your psychiatry end of rotation exam, is that you have to know timelines and be very familiar with them, and also your medications and the mode of action of medications, what classes do they fall in, what are the contraindications or side effects, etc. So this is something that we'll go over in this. And so, I mean, it might not be the same when you're in clinic. I know when I was in clinic, my doctor would see a patient and you wouldn't even ask him how long they've been having the symptoms for, and he would diagnose them with bipolar, or bipolar 1, bipolar 2. And it would just throw me off because I had memorized that you needed to know, for example, a patient with major depressive disorder, they have to be having symptoms for more than 2 weeks. And sometimes the doctor would just ask him, well, what's going on? And then he would diagnose him. So, of course, textbooks medicine is always usually different to clinical medicine. So just make sure that you keep that in mind. But for your end of rotation, make sure that you know your timelines. So major depressive disorder, we'll start with that. What is the definition? It's basically a depressed mood or loss of pleasure or interest with 5 out of 9 of the associated symptoms for more than 2 weeks. And so, according to the DSM-5, you have 9 symptoms. So the patient has to have 5 out of these 9 symptoms for them to be diagnosed with major depressive disorder. And it has to be going on for more than 2 weeks. So if you're reading the question stem and it only gives you 2 or 3, then it's not major depressive disorder, it's something else. They have to have at least 5 or more than 5 of the 9 symptoms. And they have to have absolutely no mania or hypomania, okay? And so a mnemonic that's very common for major depressive disorder, in order for you to memorize these, and that I memorized these symptoms, is SIGI CAPS. So SIGECAPS, SIGI CAPS. And so S is going to be the first one for sleep problems. The patient is going to be complaining of insomnia, or you'll have also the rare form, which is hypersomnia. So the patient is going to have trouble sleeping at night or sleeping too much. They'll have interest loss, so that's going to be the I. They'll have excessive guilt. They'll have energy loss, so they'll be feeling very fatigued. They'll have decreased concentration, appetite loss, whether their weight is going to be either increased or decreased, psychomotor changes. So basically this refers to the physical activity, and this is usually increased or decreased. Usually decrease is the most common because everything's down, right? They're feeling down for everything. And then thoughts of suicide. And finally, the somatic complaints. So they'll feel tired, fatigue, headache, abdominal pain, and muscle tension. So make sure that you also are familiar with somatic complaints. I have to tell you guys, I saw so many questions that had fatigue, headache, or the patient was having muscle tension, and it was related to depression. So make sure that you also are aware of the somatic complaints. So once again, right, that's your SIGI CAPS. Your sleep problems, your I for interest loss, E for excessive guilt. And then you have your energy loss, CAPS, lack of concentration, C, appetite changes, A, P, psychomotor changes, S, suicide, and then of course your somatic complaints of fatigue, headache, abdominal pain, and muscle tension. So once again, you have to have 5 out of 9 of these, and they have to be going on for more than 2 weeks for it to be diagnosed as major depressive disorder. Some of the key facts is that this is more common in females than males. The ages tend to be between 20 to 40, but you can also see this in elderly, and I saw this on a lot of elderly when I was rotating with my doctor. But just keep that in mind that it's more common in females. You'll have some questions asking you basically you'll have major depressive disorder, and then it'll ask you what is this most common in females, what is the age, etc. So make sure that you also know these things. Also, these patients have decreased REM latency. So they go into REM sleep quicker, and they don't have basically any restorative stages of sleep. So for those of you who are familiar with your sleep stages, right, you have your N1, N2, N3, and 4, although some books I've read that they've gotten rid of N4, but usually it's N1, N2, N3, and 4, and then you'll usually go into REM sleep. And so these patients have decreased REM latency, so they go to REM sleep quicker, skipping all these stages of N1, N2, N3, and 4. So usually N3 and N4 are considered the stages of sleep where you are the most restorative. So in these patients, they, like I said, they have decreased REM latency. So they skip all these stages and they go straight into REM sleep. And so this is why sometimes they are tired, they're fatigued, and this is something you want to make sure that you know is that they have decreased REM latency. Also, in regards to the pathophysiology of major depressive disorder, so what's going on in the neurotransmitters in the brain, is that they have decreased level of serotonin in the brain. This is also something that's really important. High yield, make sure that you highlight this. Decreased levels of serotonin in the brain, and they have high levels of cortisol. So cortisol is known as a stress neurotransmitter, and you want to make sure that you know that they have high levels of cortisol. And treatment for these patients is psychotherapy, cognitive behavioral therapy. This is usually for mild to moderate depression. I've seen these questions are like, what is the first line treatment? It's psychotherapy. And this is usually for mild to moderate depression. If it's something more severe, or if the patient's already gone to psychotherapy, cognitive behavioral therapy, and it's not working for them, then you can start them on some medications like your SSRIs and your SNRIs. So your SSRIs are going to be your paroxetine, right, your fluoxetine. Fluoxetine was the most common medication that I saw prescribed when I was in clinic. Also sertraline, so anything that ends usually in the ene, right? Paroxetine, sertraline, fluoxetine. So you have your SSRIs, and then you also have your SNRIs, your venlafaxine, your desvenlafaxine. And SNRIs, my doctor also prescribed them a lot, especially venlafaxine. But usually in the questions that I saw, it was usually your SSRIs first line, which are your fluoxetine, your sertraline. Sertraline, I saw it a lot in the question bank. So make sure that if the patient is not doing well in psychotherapy, then you prescribe him an SSRI. Or if the question asks you what is the best pharmacology treatment for this patient, make sure that you know it is SSRI, so something like fluoxetine, like I said, sertraline, even escitalopram. So these are the first line. And what is the mode of action? Basically is that they replenish serotonin levels in the synapse. And some of the side effects of these medications are that they can have headaches, GI, and sexual dysfunction is a huge one for SSRIs that I saw in the question. So make sure that you know that sexual dysfunction is very common in SSRIs and then SNRIs. And then your second line, you have things like bupropion and mirtazapine. So bupropion is actually really good for patients that are depressed and are also smoking, because it helps the patient also stop smoking. So if you have a question with a patient that is suffering with major depressive disorder and they also are a smoker, you can put them on bupropion. And then you also have mirtazapine. So mirtazapine is also good for patients that are having depression. Once again, this is second line, right? And this is also really good for patients that are also are very thin, or they don't want to eat, or they have trouble eating. My doctor prescribed this a lot, especially for patients that were elderly and they were thin. And that's why mirtazapine is also good for patients that have depression, or you will also want to increase their appetite. So if you have a question, once again, that lists as a patient that is suffering from major depressive disorder and describes a patient as cachectic or really thin, decreased appetite, then you can prescribe something like mirtazapine. And then finally, of course, you have your TCAs and MAOIs. So these are like last line. MAOIs have so many side effects, and you have to have such a strict diet when you're taking these MAOIs. So some examples of these are phenozine, and this one's actually really good in refractory depression. And the side effect of MAOI is serotonin syndrome, right? Patient will usually present with hyperthermia, seizures, clonus, hyperreflexia, agitation, metabolic acidosis, increased liver function tests. And with TCAs, they have a lot of drug-to-drug interactions. And usually some patients tend to overdose on these, so it can cause death. So that's why these drugs are usually not prescribed. And then TCAs have a lot of cardiac toxicity, so that's why they're not prescribed at all. And you want to make sure that these are third line. So if you have a question usually asking you what is like third line, then make sure you know it's TCAs and MAOIs. MAOIs, you have phenolzine, you also have selegiline, and then you have your, for TCAs, you'll have your amitriptyline, right, clomipramine, etc. So third line, TCA and MAOIs always. First line for depression is psychotherapy, right, specifically cognitive behavioral therapy. If the patient is not doing well on that, then you can prescribe them an SSRI or an SNRI, but specifically your SSRIs. And then finally, if the patient has already tried cognitive behavioral therapy, if you've put them on SSRIs and then you did SNRIs and then you did the second line treatment like bupropion, and you put them on all these medications and the patient is still not doing better, or even if the patient is pregnant, since some of these medications may be contraindicated in pregnancy, then you can do ECT, right, elective convulsive therapy, where basically if you've seen the older movies, it would do electricity in the brain. And this is actually something that's very, very safe. I know some of my classmates were rotating with some physicians that were actually considering investing in one of these machines. It's actually very safe. There's a lot of studies that are safe, and it's good for patients that are refractive or have refractive depression that is not responding to any medical treatment. And so this is safe in pregnancy and elderly. So if you have a question that says a patient has done this, this, and this, and it's not working for them, then you can consider ECT. And then, of course, the patient is always, if any situation a patient voices to you that they have thoughts of suicide, and not only thoughts of suicide, they have a plan of suicide, then that's when you want to make sure that you hospitalize them. Sometimes put them on emergency detention also. I saw that a lot when I was rotating in the hospital with my doctor. We had patients that voiced that they wanted to commit suicide, and they also had intention on committing suicide. So you can have a patient that voices suicidal thoughts, but they have no intention. But then you have a patient that voices suicide and they have an intention. Basically, they tell you how they're planning on doing it, whether it's throwing themselves off a bridge or if they have weapons at home and they plan on going home and shooting themselves. And you want to make sure that you hospitalize these patients. And there's several types of major depressive disorder. You have major depressive disorder that is chronic. It's been going on for at least 2 years. You have major depressive disorder with seasonal pattern, which is basically a presence of depressive symptoms at the same time each year, but it's very common in winter, right? Usually the patients during winter are usually don't go out as much, don't get the sun, etc., so they're more prone to get depressed. So this would be major depressive disorder with seasonal pattern, most common in winter. And the treatment for this is usually SSRIs, light therapy, like I said, so these patients aren't outside. And it's interesting, I was reading an article and it was talking about patients wearing light glasses, right? And how that has actually helped them with their depression. So light glasses, just put them on and it's light therapy. So I thought that was really interesting. And of course, bupropion, but first line is going to be SSRIs. And then you have your major depressive disorder with atypical depression features. So usually this patient experiences mood reactivity, so they have improved mood in response to positive events. So for example, the patient may be depressed and then they're going to go and watch movies and they feel better. So this would be an example of that. Signs and symptoms of major depressive disorder with atypical depression features is that they have significant weight gain, appetite increase, hypersomnia, so instead of insomnia they have hypersomnia, so they're sleeping a lot, oversensitivity to interpersonal rejection, and the treatment with this is usually SSRIs, of course. So SSRIs, you get SSRIs, I get SSRIs, everyone gets SSRIs for major depressive disorder. And then you have major depressive disorder with melancholia features. It's usually characterized by anhedonia, lack of mood reactivity, severe weight loss, excessive guilt, sleep disturbance. This tends to lead to early morning awakenings or mood that is worse in the morning. So with this one, you want to make sure that you know that this is usually a patient that's going to wake up early or they're going to feel worse in the morning. So this is major depressive disorder with melancholia features. And then you have major depressive disorder with catatonic depression. This is basically a patient that's suppressed, but they're they're physically showing it. They have motor immobility. They have extreme withdrawal, stupor. Basically, the patient will remain speechless and motionless for an extended period. So I don't know if you've seen those movies of a patient that's just depressed, and they're just looking, and they're not moving. You talk to them, and they're just looking, and they're not moving at all. This would be an example of major depressive disorder with catatonic depression. And I've seen this in clinic, and it's really sad. Basically, the patient is just emotionless. They're just staring off and not moving. It's really sad. And then, of course, your major depressive disorder with postpartum onset, usually common in women, of course, that just gave birth, and it's common within 4 weeks of birth. All right, guys. Now, moving on to the next one, let's go into persistent depressive disorder, so also known as dysthymia. So I'm trying to go through the major depressive disorders, and this is the second one. So this also known as dysthymia. You might see the answer choices as dysthymia or persistent depressive disorder, so just make sure you're familiar with both of them. It's the same thing. So basically, what is it? It's chronic depressed mood for more than 2 years in adult and more than 1 year in children or adolescents. So chronic depressed mood in more than 2 years. That's the most common one I saw in questions when I was studying. It's usually milder than major depressive disorder. The patient is still able to function normally, and once again, it's more common in females than males. So what are the signs and symptoms? In the 2 years period, the patient is not symptom-free for more than 2 months at a time, so they will say that they're always this way. So usually in the question stem, you will read a patient that is having all these depressive symptoms, right, your SIGI caps, and you'll notice that the patient has been having that for 2 years, and that's when you know it's dysthymia. Basically, their symptoms, there's going to be loss of interest, social withdrawal. At least 2 of them are going to be either insomnia or hypersomnia, fatigue, low self-esteem, decreased appetite, hopelessness, and poor concentration. And of course, the treatment is going to be similar to the major depressive disorder. You have your cognitive behavioral therapy, so your psychotherapy, first line. And then when it comes down to medications, SSRIs, first line. And then you have your SNRIs, bupropion, and then your TCAs. And then you have cyclothymic. This is basically an alternating hypomania symptoms and minor depression episodes for more than 2 years with a period of less than 2 months free of symptoms. So in comparison to dysthymia, they'll have depressed mood for more than 2 years, but the patient is not symptom-free for more than 2 months at a time. And cyclothymic, once again, is going to be alternating symptoms between hypomania and then minor depression for more than 2 years with a period of less than 2 months free of symptoms. So both dysthymia and cyclothymia can progress to bipolar. What I was reading, though, cyclothymia is a little bit more connected to bipolar than dysthymia, so just make sure that you are familiar with this. Onset, once again, for cyclothymia is similar to major depressive disorder, so the ages tend to be between 15 to 25, more common in females, once again. But these patients with cyclothymia do not have manic episodes. So a manic episode is basically an episode that affects the patient where they have to be hospitalized, whether it's they're speaking too much, or they're going out and drinking, spending a lot of money, or they're just acting erratically. Versus a hypomania, it's a milder form of this. But a maniac symptom requires a patient to be hospitalized and also affects them, their daily life. So this patient cannot function with mania. So with cyclothymia, this patient is going to have alternating hypomania, so not maniac symptoms, but hypomania with minor depressive episodes. And the treatment for cyclothymia is going to be mood stabilizers like lithium and then your neuroleptics. And for bereavement, so bereavement is common whenever an individual has a family member, right, or someone close to them, or even a friend that passed away. Interesting also, even a dog or an animal. Some people are very attached to their animals and they see them like their son or their family member. So this is common in individuals who have just lost a loved one. Definition is basically less than 2 months of depressive symptoms due to someone's death, but does not meet the criteria of major depressive disorder. So if symptoms are beyond, then you can consider major depressive disorder. So with these patients, symptoms are usually self-limiting and they last for several months. Normal bereavements should not include gross psychotic symptoms, disorganization, or active suicidality. So with bereavement, some of the questions I saw is that you usually have a patient, right, that they're it's normal if you see like your significant other, or you think you see your significant other in the crowd that passed away. So that's something normal. Actually, I remember I clicked that as something that was abnormal and I got it wrong. So of course that person is they're upset. They're thinking about their significant other. They wish that it would have been them than their significant other that passed away. So that's a normal part of bereavement. But of course, suicidality is not a normal part of bereavement. So if a patient starts stating that they want to commit suicide, then that is not normal. So you want to make sure with these patients, of course, you hospitalize them. And then you have the bipolars. So we'll start with bipolars. I think bipolar disease is very, very interesting. My doctor, I swear, he diagnosed everyone with bipolar disease. But let's start with bipolar 1. So bipolar 1, so in order to differentiate between bipolar 1 and bipolar 2 is that you have to know whether they have hypomania or maniac symptoms, and then how long they've been having them for. So bipolar 1 is basically more than one manic or mixed episode which often cycles with occasional depressive symptoms. Okay, so like I said earlier, what is a manic episode and then a hypomanic episode? A manic episode is going to be someone that does something erratically, whether it is, for example, like I said, they go to the casinos and they're spending all this money, they have this huge sex drive, they've slept with I don't know how many people. It's just something that's not normal for them. It's literally like a high and low. That's why it's called bipolar. And they'll have this high moment where they're doing all this stuff, and usually these people, they cannot function. And this is a manic episode, and usually they cannot function that they require hospitalization. So anything that requires hospitalization for a manic episode, it's going to be mania. Versus hypomania, it's a milder form. These patients can function, and these patients do not require usually hospitalization or have not had an episode of hospitalization. So if you read in a stem that this patient has had a hospitalization in the past for a manic episode, then it's mania. Okay, so if they've ever had a hospitalization event in the past, it's going to be mania. So just make sure that you know that. So bipolar, once again, more than one manic or mixed episode, which often cycles with occasional depressive symptoms episodes. So family history is really huge in bipolar. It's actually, I saw this question so many times, family history is huge. So if the patient's mother had bipolar, it's very common that that patient's also going to have bipolar, and that patient's child are also going to have bipolar. So family history is huge. It's a strong risk factor. Now, in comparison to major depressive disorder, bipolar is more common in males and females. Ages is also 20 to 30. Worse prognosis than major depressive disorder, of course, and increased suicidality compared to major depressive disorder. So a bipolar patient is more common to commit suicide than a patient that has depression. And bipolar 1 has the highest genetic link of all major psychiatric disorders, like I mentioned earlier. So what is a timeline for bipolar disease? They need to have at least, like I said, one full manic episode, which includes more than 3 of the following symptoms for more than 1 week, causing significant impairment. So bipolar 1 has to have at least one manic episode, like I said, that requires hospitalization, has affected them in their daily lives so they cannot function. And these symptoms have been going on for more than 1 week. So they have to have more than 3 of these symptoms for more than 1 week. And these symptoms are, the mnemonic that I have is going to be dig fast, so D-I-G-F-A-S-T. D, easily distracted. I, indiscretion. So it's going to be a patient that's risk-taking, that they're willing to go out and get in their car and drive 120 miles per hour. So risk-taking. G, grandiosity. F, flight of ideas. So basically this patient's just talking and talking and talking and talking and talking and talking and talking, and they can't stop. And I would see patients like that in clinic, and it was sometimes really hard to get a history from them because they're just talking really, really fast, and you can't shut them up. So flight of ideas, racing thoughts, and they're also jumping from subject to subject to subject, so their conversation is not like a conversation I'm having right now. They can be talking about their kids, and the next thing you know, they're talking about the strip club. Like, they're literally like jumping from idea to idea. So, flight of ideas. A, activities. So they have increased activities that are dangerous. S, sleep deprived. They don't sleep at night. They're more active at night. You'll have those questions that you have a patient that's just walking back and forth at night, or they haven't been able to sleep for the past 7 nights. There it is, sleep deprived. Talkativeness, like I said, pressured speech. They're talking a lot. And they also can develop some psychotic symptoms like paranoia or delusions. So that's your DIGFAST, D-I-G-F-A-S-T, easily distracted, indiscretion, grandiosity, flight of ideas, activity, sleep deprived, and talkativeness. And for these patients, the first line treatment for bipolar is going to be lithium. So you have to make sure that you know that lithium is the first line. And then, of course, if the patient for some reason cannot take lithium because they have issues with their liver or they have issues with their kidneys, then you can do something like valproic acid or carbamazepine. And lithium has actually long-term decreased suicide risk, so it helps patients decrease their suicide risk. And it has very narrow therapeutic index. Some of the toxicity is that they have coarse tremors, ataxia, convulsions, and it's category D, so it's not recommended in women that are pregnant because it can cause Epstein's, abnormality of the tricuspid valve, and floppy baby syndrome. And for a patient actually that is pregnant, you might have a question like this. For mood stabilizers, or a patient that has bipolar, you can consider something like ECT, so electroconvulsive therapy, and I even read also that benzodiazepines. So make sure that you know that you have a patient that's pregnant, you cannot give them lithium, you can do something like ECT or benzodiazepines. And then, of course, you can also do your typical antipsychotics. And one thing with these patients is that antidepressants are contraindicated or they're discouraged as monotherapy. This is textbook, but I know in clinic my doctor prescribed antidepressants, but just to make sure that textbook-wise, when you're studying for the exams, that these are contraindicated or discouraged as monotherapy treatment for bipolar. So once again, bipolar 1, first-line treatment is going to be lithium. Make sure that you're aware that lithium has a lot of side effects and is contraindicated in pregnant women. So bipolar 1 is going to be a patient, usually it's a male, in their 20 to 30s that is having a manic episode that required hospitalization. They're also having symptoms that have been going on for more than 1 week. So bipolar 1, 1 week, that's how I'm memorizing. Bipolar 1, 1 week, okay? And basically, these are causing significant impairment, these symptoms, and the patient is having more than 3 of the following symptoms. So DIGFAST, right? Your distractibility, indiscretion, grandiosity, flight of ideas, activity, sleep deprived, and talkativeness. And treatment, once again, is going to be lithium. Now let's go on to bipolar 2. So bipolar 2 is a milder form than bipolar 1. In bipolar 2, the patient can actually function. So they're able to function regularly. They've never been hospitalized and they have not had a manic episode. So once again, once a patient has a manic episode, they're considered bipolar 1. And the definition for bipolar 2 is a major depressive episode with at least one hypomanic. So not manic, hypomanic episode. So it's more than one hypomanic episode plus at least one major depressive episode. So this is actually more common in females. So in comparison from bipolar 2 to bipolar 1, bipolar 2 is actually more common in females. And bipolar 1 is more common in males, right? And hypomania is seen in bipolar 2, but is not due to substance abuse, right? So it is not due to substance abuse. And the signs and symptoms, DIGFAST once again, so it's going to be the same mnemonic, right? And these symptoms are going to be lasting more than 4 days, okay? While bipolar 1, once again, was 1, right? And it lasted more than 1 week. Bipolar 2 is going to be more than 4 days. So that's how you differentiate also between bipolar 1 and bipolar 2, or as a timeline. So that's why I'm saying, guys, make sure you know the timelines for these psychiatric illnesses. And once again, a definition of hypomania, it's a period of elevated irritable mood at least 4 days, but it does not cause marked impairment, and it has no psychotic features. So they don't have any racing thoughts or excessive agitation, and it does not require hospitalization. And the treatment, so if the patient is having an acute manic episode, you can give something like lithium, valproic acid, second-generation antipsychotics like quetiapine or lamotrigine. Depression, if they're having depression, you can give them something like Seroquel, lamotrigine, Latuda, olanzapine, Prozac. And if they're having a mixed episode, which is basically they're having both depression and then they're having a hypomanic episode, you can give them something like a second-generation antipsychotic or valproic acid also. All right, guys, so let's go into premenstrual dysphoric disorder. So premenstrual dysphoric disorder, it's basically a patient that's very irritable, they feel very anxious, restless, and this usually occurs during the premenstrual phase. So I know a lot of people are like, no, that doesn't exist, but it actually does exist, and a DSM-5 does have it as a diagnosis. So premenstrual dysphoric disorder is basically a patient that just feels anxious, restless. They're having also the symptoms of abdominal pain, usually before their period. And they have to have at least 5 symptoms that are present and have to be noted at least in at least 2 menstrual cycles. So these patients have to have these symptoms before their menstruation for at least 2 periods, so 2 menstrual cycles. If they've only had it for 1, then it's not characterized as premenstrual dysphoric disorder. They have to have it for at least 2. And symptoms are usually present before the week before menses, and they tend to improve a few days after the woman has had menses, so after their period. So symptoms: irritability, depressed mood, anxiety, anhedonia, concentration, trouble, hypersomnia, insomnia, feeling out of control, physical symptoms, breast tenderness, joint pain, weight gain, bloating. I have to say that I probably had this several times, and I bet it's very common in females before their period. And the treatment for this is going to be SSRIs. You can either give them daily or during their luteal phase. So this is also something that's also going to be high yield for premenstrual dysphoric disorder, whether it's for this EOR or your OB-GYN. I know I saw this, is that you want to make sure that you give the SSRI during daily or during the luteal phase. So luteal phase is something you have to know. Also, second line, you can do something like oral contraceptives, your GnRH agonists like leuprolide, or a bilateral oophorectomy with hysterectomy if the patient is having severe symptoms and they've tried everything and it's just not working and they don't want any children, then you can go into surgery. Okay, psychosis, guys. So what is psychosis? It's thoughts and or perceptual abnormalities not consistent with culturally appropriate norms and perceptions. So it's thoughts that are just not normal or people would not consider normal. It can be either symptoms of schizophrenia, having a manic episode, depression, delirium, dementia, or due to substance abuse or intoxication, or even induced by medications. Certain medications have side effects like psychosis. So, for the different types of psychosis, we'll start with delusions. So delusions is a fixed false belief that cannot be altered by rationalization and is not culturally appropriate. So they can be categorized into bizarre, so something that's basically impossible, like saying you had aliens abducted or aliens are following me. And then something non-bizarre, which is something that may be real. Maybe, you know, the patient's saying that the FBI is following them. Well, that can happen. Or there's a police officer that sits outside my house and I watch them through the window every day and they're there. So that's something that's non-bizarre, right? But then you have your bizarre ones like I got abducted by an alien, or I've heard ones like Chupacabras is out to get me, or etc. So basically non-bizarre, false belief that's plausible but not true. Like I said, neighbors are spying on me by reading my mail. And there's several types of delusions. So you'll have your persecutory ones where you feel that someone is out to get you, someone's out to harm you, the CIA is after you, they've tapped your phone. I saw so many of these when I worked in, when I did my psychiatry rotation, so many. Persecutory is one of the common ones that I saw a lot. And then you have your ideas of reference, so random events are taking place directed at them. Like for example, the patient is watching TV and they think that the person that is talking in the news is talking to them or is talking about them. So they'll say, I know I had a question that said, oh, there was a 49-year-old male that robbed this store and we are looking for them. And then the patient's watching TV and they're like, oh my gosh, they're talking about me, I'm 49 years old. So it's an idea reference basically that everything is directed at them. And then you have your delusion of control. So some agency, for example, controls a patient's thoughts, feelings. Then you have your grandiose. You think that it's an unrealistic belief in one's power and ability. So someone thinks that they're God or they have superpowers. Nihilism, which is an exaggerated belief in the futility of everything in catastrophic events. So it's a belief that all values are baseless and that nothing can be known or communicated. Arithmetic, where you believe someone else is in love with them, like you think Justin Bieber is in love with you, you think Taylor Swift is your wife, etc. Doubles, they think that their wife or someone close to them has been replaced by identical double. So they think that their child is not their child, that it's someone else. Jealousy, so that one's also very common that I saw. Someone believes that their significant other is being unfaithful to them. Somatic delusions is that they believe that they're infected with the disease. Oh my gosh, I saw this so much in the clinic, especially patients that think that they have parasites in them. They just start picking at their skin, and they think that they have parasites. And I saw this a lot, especially on patients that were taking cocaine. And when they were off cocaine, they started picking at their skin, and they felt like there was bugs inside them, or they thought there were parasites in them. And then after they were off the cocaine for a few days and my doctor treated them, it was like a completely different person. So I saw this one also, somatic delusions. And then you have your perceptual disturbances. So this is also another one of the psychosis. So perceptual delusions. So under these, you have hallucinations. It's a sensory experience without discernible external stimuli. So some of these hallucinations include auditory. This is actually the most common one, where the patient hears sounds or voices that are talking to them. This is actually very common in patients that have schizophrenia, and I saw this a lot. When we were in clinic and even in the hospital, when I would be running with patients, every day we asked them if they were having any auditory or visual hallucinations, and we would write it down. And you would have patients that say that they would hear voices, that they're talking to them. And then the next type is going to be your visual hallucinations, right, where they actually see things. They see faces, they see flashing lights. I had a patient that said that she saw beans flying in the air. She's like, veo frijoles en el aire. Or she would say that she saw bracelets flying in the air. So visual hallucination, something that's not there. It's something that their mind is making them see or they're perceiving. Olfactory also, smells. Tactile, insects on their skin or that they're being touched. Like I said, with these, you want to consider something like alcohol use disorder, alcohol withdrawal, amphetamine use disorder, somatic, sensation arising from within the body, gustatory, which can be part of a persecutary delusions, tasting poison in food. And then you have your illusions. So this is different, right, from hallucinations. Illusions is a misinterpretation of existing external stimuli. So that's how hallucinations is something that's basically not there, right? And then misinterpretation is that you see something but you misinterpret it. So I can see the painting and it's moving, but it's not really moving, right? So that's how you differentiate between illusions and hallucinations. So with these, basically you'll have a question and it'll give you an example, and you have to know that it's an illusion, or you have to know it's a hallucination, and you have to know it's a somatic hallucination. So you have to make sure that you're very familiar with these. And some of the causes for hallucinations and illusions are multiple sclerosis, Alzheimer's, Parkinson's, Huntington's, epilepsy, hypo and even hyperthyroidism, Addison's, Cushing's disease, nutritional deficiencies like vitamin B12 deficiency, folates, niacin, also SLE, temporal arteritis. So these are some of the causes of possible psychosis. And let's jump into schizophrenia. I love schizophrenia. It's really, really interesting. So schizophrenia, it's characterized by a constellation of abnormalities in thinking, emotion, and behavior. So with schizophrenia, the patient has to be having symptoms for more than 6 months, okay? With 1 month of acute symptoms with functional decline. So usually in a question time, you'll see a patient that they've been declining, they haven't been taking care of themselves, they haven't been showering, their facial expressions are changing, and then that's when you're like, I think this is schizophrenia. And with schizophrenia, you'll have your positive and negative symptoms. This is really important that you know the difference because I had a lot of test questions on this. So your positive symptoms in regards to the pathology, it's due to, they think, excess dopamine receptors in the mesolimbic pathway. So positive symptoms, excess dopamine receptors in the mesolimbic pathway. And some of the positive symptoms include hallucinations, delusions, disorganized speech and thinking, and abnormal behavior. Now let's go on to negative symptoms. This is due to dopamine dysfunction in the mesocortical pathway. And usually with these patients, some of the symptoms is that they'll have problems with their affect. So they'll have a flat emotional affect, social withdrawal, lack of emotional expression. So they'll have literally like this face that's just flat, no emotional expression whatsoever. Evolution, basically lack of self-motivation, apathy, they don't care for anybody or even themselves. Anhedonia, they have no interest in anything. Attention, it's usually poor, so they can't keep an attention, it's usually non-existent. Alogia, poverty of speech, so even sometimes complete lack of speech, and lack of communication and reactivity, and silent patience or poor eye contact. So these are the ones for negative symptoms. So once again, make sure you know also the pathophysiology. Positive symptoms is usually due to an excess dopamine receptors in the mesolimbic pathway, and negative symptoms is usually due to a dopamine dysfunction in the mesocortical pathway. So usually they'll give you a question that you'll have a patient that's schizophrenic, and they'll tell you it's schizophrenic and they're having hallucinations, and they'll ask you what is the pathophysiology, and you have to know, okay? And for negative symptoms, make sure you know it's the 5 A's, right? It's anhedonia, affect, alogia, evolution, and attention. That's how I memorize them, the 5 A's. Okay, now in regards to how long do the signs and symptoms have to be present? So like I said, they have to be present for more than 6 months. And they usually have different phases. So you'll have the prodromal phase, which is usually the gradual deterioration of functioning. So this is when the patient starts having symptoms of schizophrenia. So they'll start with their disorganized speech, their behavior, disorganized behavior, delusions, hallucinations, and then they'll move on to the psychotic phase, where they start having perceptual disturbances, delusions, disordered thought, process, and content. And then they'll have the residual phase, which is persistent deterioration of functioning with negative symptoms even after delusions, hallucinations are gone. So make sure that you know these different types: prodromal, psychotic, and then residual, which is the last one. Residual is basically that they have persistent deterioration, like I said, with negative symptoms. And in regards to labs that you want to do for patients at schizophrenia, you always want to make sure, as always, for everything, for OB-GYN, everything, you want to rule out hypo or hyperthyroidism, right? So you want to do a TSH, you want to do an RPR, just make sure it's not related to anything infectious like syphilis, right? Brain imaging, make sure it's not anything related to a tumor or even an infection, whether it's bacterial or viral, parasitic. So you want to make sure that it's nothing related to, I would say, like an organic cause, right? And drug screen also. So just make sure that they're not on medications that might be causing all these symptoms. So there's different classifications of schizophrenia. I don't know if you guys have seen that movie with Jim Carrey. It's called Me, Myself, and I, and that's how I actually was able to memorize and learn a lot about schizophrenia. So you'll have the paranoid type, and that's what Jim Carrey was in Me, Myself, and I. That's what he was diagnosed for when he was holding the pills and he's shaking and he's taking them with water. When they asked him, like, what are you taking them for? He was like, paranoid schizophrenic, and he's saying it super fast. So that's what he had. So the paranoid type, this one actually has the best prognosis. These patients are usually preoccupied with delusions or auditory hallucinations, and they don't have disorganized speech, behavior, or inappropriate affect. And then you have your disorganized type. So this one has the worst prognosis. Prominent disorganized speech and behavior. You have your catatonic type, right? This is 2 or more of the following: immobility of motor activity, excessive purposeless motor activity. We saw catatonic also in major depressive disorder, right? So this one is also common in schizophrenia. Basically, the patient is not moving. They even say that they have that waxy movement, is that you move their hand a certain way and they'll stay that way. If you see some videos on YouTube, it's pretty sad and it's pretty interesting. Just type in catatonic schizophrenia. And then you have your echolalia, which is patient is repeating the question. So you'll ask them a question and they'll repeat it after you. Echopraxia is that they're mimicking your actions. So if you move a certain way, they're just mimicking you, whatever you do. Mutism, the patient will just stay quiet. They will not engage in the conversation with you or with the environment around them. So risk factor for this one is also family history. It has a high genetic cause also for this one, for schizophrenia. And key facts. So usually the onset for this for men is a lot earlier than for women. And like we said, it's more common in men than women, right? The onset age for men is usually at 20 years, while for women it's at 30 years. And men tend to have a worse prognosis and more negative symptoms than women. Also, substance abuse and suicide is very common in patients that have schizophrenia. And CT and MRIs in patients in schizophrenic patients shows enlarged ventricles and diffuse cortical atrophy and reduced brain volume. So I had a question on this, and I put a star by it. So once again, CT MRI in a schizophrenic patient, what will it show? It'll show enlarged ventricles and diffuse cortical atrophy and reduced brain volume. So what are some of the factors that are associated with a patient having a better prognosis and then a patient having a worse prognosis with schizophrenia? So this is something also that's very high yield. You have to make sure that you know this. I had these questions in several forms in my question banks. So factors associated with better prognosis: later onset, good social support, positive symptoms, mood symptoms, acute onset, female gender, few relapses, and good premorbid functioning. The common ones I saw were later onset, so for better prognosis, positive symptoms, acute onset, female gender, and fewer relapses. Now, what are some of the factors associated in schizophrenia with a patient having a worse prognosis? Early onset, okay, so the earlier disease, the worse it is in a patient with schizophrenia. Poor social support, right? Patients that are homeless, poor social support. Negative symptoms, so the more negative symptoms that they have, the worse prognosis that they have. Family history, if their uncle or if their mom had it, then they have a worse prognosis. Gradual onset rather than acute onset. Gradual onset is associated with worse prognosis. If they're a male, if they had many relapses. Poor morbid functioning, comorbid substance abuse also. So once again, we're going to go through the pathophysiology of schizophrenia. It's something also that's very high yield. You're going to get this in questions for sure. So patients with schizophrenia have decreased central nervous system gray matter. They have the increase in the size of their ventricles and increased CNS dopamine receptors. I actually had to explain this to a patient because she didn't understand why they had given her a certain medication and why it causes symptoms that she was taking. And so I'm pretty glad and I'm happy that I learned this information, and I made sure that I drilled this in my head because I had to explain how there's an excess of dopamine and how these medications basically deplete dopamine. And if you deplete all your dopamine, you're going to have these symptoms. And so it's really important also that you know this just for yourself, especially when it comes down to medications. If you know the pathophysiology of schizophrenia, then knowing what the medications do and what steps do they affect will help you a lot. So pathophysiology, dopaminergic pathway. So you have the mesolimbic pathway. It runs from the ventral tegmental area to the nucleus accumbens. Okay, nucleus accumbens is also known as a pleasure center and is stimulated by the neurotransmitter dopamine. And this pathway is responsible for perception. So mesolimbic pathway is responsible for perception, emotions, arousal, memory, behavioral system. And excess dopamine leads to positive symptoms. So increased dopamine, positive symptoms, okay? So like I said, antipsychotics work on this pathway to treat positive symptoms. So they usually will deplete the dopamine or decrease the dopamine. And then you have the mesocortical pathway. This pathway will run from the ventral tegmental area to the prefrontal cortex. It's associated with motivation, personality, cognition, executive functioning. Here, decreased dopaminergic activity due to antipsychotic use will cause negative symptoms. And then you have your nigrostriatal pathway. This runs from the substantia nigra area to the basal ganglia, and this pathway is responsible for movement. And depletion of dopamine here leads to the Parkinson's symptoms, so extrapyramidal side effects. And the nigrostriatal pathway is usually blocked by antipsychotics, and they tend to cause, like I said, Parkinson's symptoms, like your tremor, your rigidity, your slurred speech, your dystonia, your akathisia, which is like restlessness. The patient cannot sit. And then you have your tubero-infundibular pathway, which runs from the hypothalamus to the pituitary, and this allows dopamine to exhibit negative feedback on prolactin secretion. And when we deplete dopamine, prolactin then is unimpaired, which can cause galactorrhea. So this pathway, the tubero-infundibular pathway, is blocked by a lot of antipsychotics, and this is why a lot of patients that are on antipsychotics can have hyperprolactinemia. So what are symptoms of hyperprolactinemia? They'll have gynecomastia, galactorrhea, sexual dysfunction, and menstrual irregularities. And I actually saw this a lot on patients that were schizophrenics and they were on antipsychotics. Women, they would complain that they are having a lot of milk or white liquid coming out of their breasts, and they would tell me, I'm not pregnant, I don't know why I'm having these symptoms. And I would explain to them that it was because of the medication that they're taking. And then this is where you explain to them the pathway, the pathophysiology, and then they understand it better. So what is a treatment for schizophrenia? So the treatment is going to be a dopamine receptor antagonist, right? Because we just talked about the pathophysiology is that in schizophrenia, they have an excess amount of dopamine. So you want to make sure that you antagonize or you decrease the amount of dopamine that's being released. So second generation antipsychotics are actually first line. Why? You have your first generation and you have your second generation. I'm actually going to talk about medications later, and we'll be talking about the differences between first and second generation because medications are also very heavily tested on the exam. So second generations are usually the newer generation medications. So they're the atypical antipsychotics, and they're newer because they have less side effects. And then you have your first generation medications that have a lot more side effects than the second generation. And I'm not sure if you've seen the movie Shutter Island with Leonardo DiCaprio. It's a good movie. It's a great movie. When I was studying for this exam, I watched that movie, and in that movie, he's actually having symptoms of the first generation antipsychotics that they give him. I don't know if you noticed at the end that he was like sweating and he was even shaking. Those are some of the symptoms that the first generation antipsychotics have. If you haven't seen that movie, I really recommend it. I loved it. And during that movie, it was interesting because they had just come out with the first generation antipsychotic. I don't remember what it was. But once I go through this, I know I wrote it through here and I'll let you guys know. But it was a first generation medication that had just come out and they had given it to him. And throughout the movie, he's experiencing these symptoms from these antipsychotics. So first generation typical have a lot more side effects than second generation. So this is why second generations are first line for schizophrenia. So some examples are risperidone, olanzapine, quetiapine, clozapine. And their mode of action is dopamine and serotonin antagonists versus the first generation that tend to only work on dopamine. Second generation work on both dopamine and serotonin. So that's why it's a lot better because they don't only deplete all your dopamine, they work on both dopamine and serotonin for the second generation. So clozapine is used in refractory cases. So if the patient has not improved after 2 to 6 weeks of, for example, risperidone, which is something that my doctor prescribed a lot, then you would consider clozapine. But clozapine has a lot of side effects, like agranulocytosis. It just has a lot of side effects. So that's why we try to stay away from that medication. And then for olanzapine, quetiapine, you want to monitor at baseline for metabolic syndrome. You always want to get an A1C level. You want to measure the lipid panel, weight check, waist circumference, blood pressure, EKG for these antipsychotics because they have a lot of side effects. So first generation is going to be second line. So once again, second generation's first line. First generation is going to be second line. Sorry, tongue twister. So first generation medications like Haldol, chlorpromazine, they're better at treating the positive symptoms but are associated with increased extrapyramidal side effects. So second generation medications, they treat both the positive and the negative side effects. So like we listed earlier, right, we were talking about the positive and the negative symptoms. First generation only treats symptoms but are associated with more side effects, especially the extrapyramidal side effects. And then second generation treat both positive and negative. This is why they're a lot better than the first generation medications. And what are some examples of extrapyramidal side effects? So you have dystonia, which is basically one of the first symptoms that you might see after giving an antipsychotic is that they'll have severe muscle spasms like a locked jaw. And this occurs hours to days. They'll have spasm of the tongue, neck, face, and back. Also make sure that you're very familiar with these because I had questions with the patient stating that they were an antipsychotic. You always have to know that it's first generation because first generation have higher extrapyramidal side effects, which are the ones I'm going to discuss right now. They have just worse side effects in general in comparison to the second generation antipsychotics. So first generation antipsychotics are bad. And if you see some type of extrapyramidal side effects, just make sure that it's due to a first generation antipsychotic. So some of these extrapyramidal side effects, like I said, dystonia, you're going to treat dystonia with Benadryl or benztropine. And I actually saw a patient with dystonia. Pretty interesting. We did the same thing. We gave him a cocktail, gave him a IM intramuscular Benadryl or benztropine, depends. And we had a patient that was actually hospitalized because they were having dystonia, and the parents were actually very freaked out. And she was given benztropine, and she didn't know what benztropine is, or also known as Cogentin. So like I said, your first generation antipsychotics, what do? They deplete or they decrease your dopamine, because in schizophrenia, the problem is that you have increased dopamine, right, in your brain. And so first generation antipsychotics will deplete that, and sometimes they'll deplete it so much that sometimes you don't have as much dopamine as a normal person does, and that's where you start having all these symptoms. And that's why you give medications like benztropine, and benztropine will actually help get that level of dopamine to the normal level, or increase your levels of dopamine. And this is something I had to explain to a patient also, because they weren't sure why they were taking benztropine. And then another extrapyramidal side effect is something known as akathisia. This one occurs hours to days. The patient will usually have compulsive, repetitive motions, agitation. They feel like a sense of restlessness, like they have to move. And the treatment for this is beta blockers. And then you have your Parkinsonism symptoms, which is usually found in a patient from 5 to 30 days. They'll have tremor, shuffling gait, drooling, stooped posture, instability. It's called Parkinsonism because their symptoms are very common. If you're familiar with Parkinson's, symptoms very familiar or common in Parkinson's. So that's why they're called Parkinsonism symptoms. And usually this will be months after they've been taking the medication. And with that, treatment's going to be amantadine, right? It's going to be a dopamine promoter. So all these medications are helping increase their dopamine levels, or something like cogentin once again. And then you have tardive dyskinesia. So this is actually years after initiation. And I saw this one. This was actually very interesting if you Google it. I saw it in a patient. She basically was like going like this with her lips when I was talking to her, like all the time. And it's really sad because they have this urge to just repeat these like oral facial movements, and for her it was like her lips. She just kept moving her lips like this when she was talking. And this is usually due to years after they've been taking these antipsychotics. So once again, these are common in first generation antipsychotics medications, so they're common side effects. And with these patients, you basically want to discontinue or lower their antipsychotics, or switch to atypical antipsychotics, like I said, the second generation, or even giving something like Ingrezza or valbenazine. And then you have your neuroleptic malignant syndrome. Okay? So what is neuroleptic malignant syndrome? This is usually also due to antipsychotic medications. Basically what they will have, symptoms, the patient will have ultramental status, lead pipe rigidity, hypertension, hyperthermia, tachycardia, leukocytosis, metabolic acidosis, and hyporeflexia. Treatment for this is bromocriptine, dantrolene, or cooling blankets. Usually you'll see these patients in the ER. That's where you want to make sure that you're taking a good history and seeing what medications that they're taking, because this can be an emergency. Usually first line is that you want to do a cooling blankets, give them something like dantrolene and bromocriptine. Alright guys, so we're done with schizophrenia. Let's go on to brief psychotic disorder. So the definition is a psychotic symptom that lasts from day 1 to 1 month. So 1 day to 1 month, and they return back to normal level of functioning. So that's why it's called brief psychotic disorder. So they'll have psychotic symptoms. It's going to be from day 1 to 1 month, but then they start doing well after the month. And treatment is usually brief hospitalization. You can give them some antipsychotics for psychosis or benzos for agitation. And then we have a schizophreniform. So what is the definition? Schizophreniform basically meets the criteria for schizophrenia, but symptoms last from 1 month to less than 6 months duration. So like we learned earlier, right, schizophrenia is more than 6 months. Schizophreniform is only from 1 month to 6 months. So if you're reading a question and the patient is having your symptoms of schizophrenia, then like your dig fast, right, then and you read and you see that they've only been having it for 2 months, then you would suspect something like schizophreniform, right? Because schizophreniform is from 1 month to 6 months. And usually the prognosis for this is that 1/3 of these patients actually recover completely, and 2/3 tend to progress to schizoaffective disorder or schizophrenia. So this is something that's really important that you need to know. I had a lot of questions that basically would give you a patient that had schizophreniform, and they would ask you, what will this patient likely progress to? And you want to make sure that it's related to schizophrenia and also schizoaffective disorder. Treatment for this is hospitalization if it's needed, and 6-month course of antipsychotics and psychotherapy. And then we have our schizoaffective disorder, which is basically a schizophrenia plus mood disorders. So they'll have schizophrenia symptoms, but they'll also have symptoms of being depressed or a manic episode. Psychosis is basically the primary pathology, and psychosis has to occur by itself. The psychosis that occurs without any mood disorder is usually greater than 2 weeks. So schizoaffective is that they'll have schizophrenia mood disturbance for more than 2 weeks. So once again, timelines are really, really important, okay? So schizoaffective disorder, psychosis has to occur by itself, and usually they'll have schizophrenia and mood disturbance. Usually you'll read a patient that's like, they're depressed and they're sad, but they're also having symptoms of schizophrenia, and it's been going on for like 2 weeks, and you're like, okay, it's schizoaffective. If they do have a mood disorder, it's usually depression, but it can be also manic or mixed, and it occurs for the majority of the time in psychosis. So a treatment for these patients, it's going to be antipsychotics and SSRIs or a mood stabilizer. Okay? And then you have your delusional disorder. So delusional disorder is basically a persistent fixed delusion for more than 1 month, which does not lead to functional impairment. Okay? So this is the difference between schizophrenia and delusion, is that schizophrenia has bizarre delusions, right, or non-bizarre delusions, and they have impaired daily functioning. And delusional disorder is usually something that's non-bizarre, and this patient's able to function daily, okay? And the treatment for delusional disorders are antipsychotics, cognitive behavioral therapy, but no group therapy, because usually these patients are so delusional that if you do put them in group therapy, they think that the person next to them is plotting something against them and they're talking about them, or etc. So that's why you want to make sure with these patients it's usually independent therapy, cognitive behavioral therapy, no group therapy. And then you have your schizotypal disorder, right? Medcomic has a great picture. If you Google Medcomic, it has a great comic for schizotypal, and it's basically someone dressed up as a clown and they're saying these funny things. Basically with schizotypal, the definition is paranoid, odd or magical beliefs, eccentric, lack of friends, social anxiety. Basically it's a patient that they dress, you'll read the question and it will say that they dress funny. That's something that I kept seeing over and over again in the question stems, is that a patient that just dresses funny or has funny beliefs. I had a question of a woman that was outside and she had a glass ball and she thought that she could tell people's futures, and she was dressed really weird, and that was schizotypal. So it's just an odd belief. And then schizoid, these patients, schizoid, afraid, they like to be alone. So solitary activities, lack of enjoyment from social interactions, no psychosis. So schizoid, usually a patient in the question stem, it'll be someone that is alone. They like to be alone and they prefer to be alone. So I know I had a question of a patient that likes to work in the lab because they're alone, and it was schizoid. I was so mad because I got it wrong, but it was schizoid. So patient that likes to do solitary. Alright guys, so we're done with major depressive disorder, schizophrenia, and bipolar. We have a lot more to go, so now we're going to go with substance abuse and somatic symptom disorder, okay? So let's start with substance abuse. And first off, let's start with the criteria for substance use disorders. So they basically have to have 2 or more symptoms, according to the DSM-5, for more than 12 months. I kept getting this wrong and I was so mad. So criteria for substance use disorder, 2 or more symptoms of the ones I'm going to list below for more than 12 months. Symptoms include increasing use of substance more than intended, cravings to use, failure to fulfill obligations because of the substance, preoccupation with getting substances, so they're worried and they're always busy trying to get more meth or whatever their substance abuse is, placing themselves in a dangerous situation to use substances, significant time spent to obtain, use, and recover from substances, continued use despite significant and social and interpersonal problems, decreased activities because of substance use, repeated desire and attempt to quit without success, tolerance, and withdrawal symptoms from non-use of substance. So once again, they have to have 2 or more of these symptoms that I listed for over the past 12 months. So make sure you're very familiar with these because they change from DSM-5 to DSM-4. So I had some questions that listed some from DSM-4 that were not part of DSM-5, and I kept getting them wrong. So just make sure that you're very familiar with the criteria for substance use disorder. Now, How do you differentiate between mild use, moderate, and severe? That's something also really important, high yield, you have to know. Mild use is basically they're going to have 2 or 3 symptoms of the ones I just listed. Moderate, it's going to be 4 to 5 symptoms of the ones I listed, and severe is going to be more than 6 symptoms of the ones I listed. So if a patient is in early remission, they'll have 3 to 12 months of sobriety from substance, and in sustained remission, more than 12 months of sobriety. So I also had questions on these also. What is the difference between early remission and sustained remission? Make sure that you know the timeline. So early remission, 3 to 12 months of sobriety from substance use, and sustained is that it's been more than 12 months or more than a year. And some questions, for example, I had, which of the following factors is associated with the highest risk of substance use disorder? Is current use of one substance, right? So if the patient smokes or smokes marijuana, they have a higher risk of developing a substance use disorder. Okay, urine drug screen. So urine drug screen for patients with substance use disorder. It's very specific for cocaine, and usually if it's positive, it means that they used it. And usually in alcohol, for the normal blood level of alcohol is 80 milligrams, and blood alcohol level tends to decrease in 20 to 25 hours. So usually if you do a urine drug screen after a day or so, it might not be as specific. For PCP, some of the labs that you want to do is you want to do an AST and a CPK. So CPK is a creatine phosphokinase test, and usually this will be elevated. So AST, liver enzyme. And then for spice, you can't identify this usually in a urine drug screen. All right, guys, let's go into alcohol use disorder. So the alcohol use disorder, the criteria is different in comparison to men and women. It's a little bit more drinks for men than for women. So for men, the criteria is 4 drinks per day or more than 14 drinks per week, averaged over 4 weeks. So usually you'll have a question stem. If it's, for example, if this patient had 2 drinks per day, then they wouldn't have an alcohol use disorder, right? Or you wouldn't consider screening them for an alcohol use disorder. But for men, it's more than 4 drinks per day or more than 14 drinks per week, averaged over 4 weeks. Women, this is where it changes. It's 3 drinks per day or more than 7 drinks per week over 4 weeks. So what is the pathology for alcohol use disorder? And actually, I even highlighted this and I put so many stars on it because I had questions on this. So alcohol activates GABA, which is an inhibitory neurotransmitter, dopamine and serotonin, which are inhibitory neurotransmitters also. But it inhibits glutamate, which is an excitatory neurotransmitter, thus depressing the central nervous system activity. So you have to make sure that with alcohol use disorder, what it does is that it activates your GABA, dopamine, and serotonin in your brain, but it inhibits glutamate. Okay, and chronic activation and downregulation of GABA during intoxication can cause a chronic blockade of your NMDA, which is a glutamate receptor subtype, and an upregulation or increased production during intoxication. So what is the workup for alcohol use disorder? So the labs. Usually this patient will present with macrocytic anemia, so they'll have an increased MCV, right? And they'll also have increased hepatic enzymes, especially their GGT. I saw that in clinic. I got pimped on it, so you make sure you're familiar with GGT. They had increased GGT, and their AST will be higher than their ALT. So that's something that's very specific in how to differentiate between, for example, cirrhosis of or injury to the liver due to a viral disease like hepatitis and something due to alcohol. So in alcohol, it's going to be ASTs greater than ALT, right? And then they'll also have decreased vitamin B12, folate, magnesium, and platelets for their labs. And genetics, interestingly, is that it's 4 times more common in children with parents that have used. So I can say this is true. Usually if the father, for example, has an alcohol use disorder, then it's more likely like the child will also have an alcohol use disorder when they grow up. And for their physical exam, you'll usually see in someone that has been using alcohol for a while is that you'll see a painless hepatic enlargement. They'll have a beer belly, right? Amnesia, ascites, cirrhosis, testicular atrophy. That one was big. I actually put a star next to that one. Gynecomastia, right? So they might develop breasts. spider angiomata, so on their abdominal area you might see like spider veins, and imaging. So for these patients, you want to do an MRI, right? You'll see a damage to their medial dorsal nucleus of the thalamus and mammillary bodies. Usually the memory is affected. And now, since we're under the umbrella of alcohol use disorder, let's differentiate between alcohol intoxication and alcohol withdrawal. So alcohol intoxication, some of the clinical manifestations for alcohol intoxication is that they'll have slurred speech, ataxia, decreased attention and judgment, labile mood, erratic behavior or aggression. So this is common in someone you see when they're drunk, right? They can't walk, right? Their attention and judgment is really poor. They might be aggressive. Their speech is like all over the place. You can't understand them. Versus alcohol withdrawal. So what is the pathophysiology of alcohol withdrawal? So we already went over basically what are the neurotransmitters involved, how does it affect alcohol, how does alcohol affect them. So the pathology for alcohol withdrawal is that in chronic alcoholics, they have a lot of NMDA and few GABA receptors. So this is something you have to know. So a lot of NMDA and few GABA receptors. So they have upregulation of NMDA and downregulation of GABA. And the clinical manifestations for alcohol withdrawal, if it's uncomplicated, it's usually between 6 to 24 hours after their last drinks. So they'll have the shakes, their anxiety, tremors, nausea, vomiting, tachycardia, irritability, and insomnia. For withdrawal seizures, it tends to occur between 12 to 48 hours after their last drinks, and it peaks at 24 to 48 hours. So they'll have the generalized tonic-clonic type, and it's very common in a single episode. And they can also have hallucinations. It tends to occur between 1 to 3 days post-drink. They'll have vivid, unpleasantry, auditory, visual, or tactile hallucinations without altered mental status. And it tends to last 1 week. And then delirium tremens. So this is actually one of the more severe ones. So if you notice, I'm actually going in regards to timeline. So at 6 to 24 hours, it's complicated. They'll have the shakes. Withdrawal seizures will tend to happen between 12 to 48 hours. The most common type is generalized tonic-clonic type. So make sure you know this. I had a question on this and you had to know what type. So generalized tonic-clonic is the most common type for withdrawal seizures and alcohol use disorders. And it's 12 to 48 hours after the last drink. Then hallucination is the next one. It occurs 1 to 3 days after their drink. And then delirium tremens, which is 2 to 3 days post-drink, and it peaks at 3 to 5 days. So these patients will have altered mental status, agitation, fever is big, autonomic hyperarousal, tremor, and then visual hallucinations. And it can be deadly if the patient doesn't receive any treatment. So delirium tremens, make sure that this is associated with alcohol withdrawal, okay? And treatment for withdrawal disorder is IV benzodiazepines. Why? Right? They potentiate GABA. So remember we were talking about how in patients that have alcohol withdrawal, the pathophysiology is that they have very few GABA receptors. They've depleted all of them. And so with benzodiazepines, what they do is that they potentiate GABA, right? They help you increase that amount of GABA that you've depleted. And so you have different types of benzodiazepines. You have your high potency like alprazolam, also known as Xanax, clonazepam, Klonopin, and lorazepam, Ativan. And then you have your medium potency, diazepam, which is usually used for the seizures that patients have in alcohol use withdrawal. And then you have your low potency like Librium and temazepam, also known as Restoril. So you want to make sure that you give also chlordioxepine or diazepam to decrease alcohol abuse potential. So this is also something that I highlighted. So if it asks you, what can you give this patient to decrease abuse potential, diazepam or chlordiazepoxide, okay? And if the patient has liver damage or cirrhosis, you want to give something like lorazepam because it's not metabolized by the liver. So make sure that you know this, okay? So if you have a patient, alcohol use disorder, treatment and they have trouble with their liver or they have cirrhosis already, then you can consider something like lorazepam. And remember that benzodiazepines that have a shorter half-life have an increased potential of addiction, right? So that makes sense, right? Because they want to keep taking it over and over again. Versus also higher potency are also more addictive. Also another treatment that you want to do for these patients is that you want to do IV fluids and supplementation. So give them IV thiamine and magnesium before glucose administration. So that's something that's high yield guys. For if it asks you what fluids do you want to give to these patients, make sure you always give them thiamine and IV thiamine and magnesium before glucose administration. Okay. You also want to give them multivitamins, including vitamin B12 and folate, because most of these patients, like I said, usually have macrocytic anemia, folate deficiency anemia, iron deficiency anemia. So that's why you want to give them B12 and folate. IV fluids and dextrose also. You want to make sure that you give them fluids because some of these patients have been throwing up a lot. So make sure they give them IV fluids. And gabapentin can also be helpful with their pain, anxiety, insomnia. And it's not addictive, and it can also assist with sobriety. Okay, and alcohol dependence. So, what is the definition of alcohol dependence? It's alcohol abuse that becomes dependence when withdrawal symptoms develop or tolerance. So, usually, when you're asking a patient whether or you suspect that they have alcohol dependence, you ask them questions like the CAGE. For those of you who are familiar with CAGE, right? So, cut down. Have you felt the need to cut down? Annoyed. Have people told you that they were annoyed when you drink? Like, for example, is your wife annoyed when you drink? Guilt. Do you feel guilty about your drinking? And E, eye opener. Have you needed an eye opener to start your day or reduce jitteriness? And usually the management for alcohol dependence, supportive, psychotherapy, you have your Alcohol Anonymous, right, or rehab, disulfiram, naltrexone. Okay, so naltrexone, I always memorize that the T for naltrexone is going to be long, right? So it's usually long-term treatment versus naloxone is going to be acute. So naltrexone is long-term. Gabapentin, topiramate, and then treatment for alcohol use disorder is for an acute. You want to give thiamine, then glucose plus folate supplementation. So remember, I had said it's high yield. So you always want to give thiamine before glucose. Okay. Because if you do give glucose before thiamine, you can do Korsakoff syndrome, and that's actually can turn pretty deadly, especially in alcoholics. So first line treatment for alcohol disorder is going to be naltrexone, like I stated. So naltrexone is an opioid antagonist, and it decreases their pleasure and craving for alcohol. You can also do a camprosate, which is a glutamate receptor modulator, and it maintains abstinence and it is renally metabolized. So my doctor actually prescribed a lot of camprosate for a lot of patients that did have alcohol use disorder. But I know most of the questions that I saw, it was naltrexone for the first line. Second line, you can do something like disulfiram. It inhibits aldehyde dehydrogenase and makes acetaldehyde accumulate. But it has some side effects like flushing, nausea, vomiting, palpitations, shortness of breath, headache, especially if alcohol is consumed. And it's contraindicated in patients that have cardiac disease, diabetes mellitus, hypothyroidism, epilepsy, kidney, or liver disease. So basically, the disulfiram is that if the patient's taking it and they take alcohol, it makes them really sick. But easily with this treatment, the patient can stop taking the treatment and then they can keep drinking alcohol and they'll be fine. It only occurs as long as you're taking the medication. So that's why it's second line, because there's a way you can get around it. And that's why naltrexone is preferred over this. And you can give also topiramate, which is an anticonvulsant. This also helps in reducing cravings. It helps with sobriety and also helps with weight loss. For psychosis, so if a patient is psychotic or they're very aggressive, you can do something like Haldol or Risperdal. And patients also tend to be sedated, right? And then therapy, like I said, Alcohol Anonymous and motivational interviewing. So some of the symptoms that you want to watch for is peripheral neuropathy. Usually they'll be complaining of the stocking glove syndrome. Wernicke's encephalopathy, which is usually due to thiamine deficiency, so vitamin B1. I had a question on Wernicke's encephalopathy, and it asked what was it due to, and it didn't have thiamine deficiency as an answer choice. It had vitamin A, B, C, and D. So just make sure that its thiamine deficiency is also vitamin B1. So I just remember for that question, thankfully, I remember vitamin B, so I ended up choosing vitamin B and I got it right. So just make sure that thiamine is also known as vitamin B1, so don't only memorize thiamine. So Wernicke's encephalopathy is used due to thiamine deficiency or due to vitamin B1 deficiency. Some of the signs and symptoms are confusion, ataxia, nystagmus, and it's reversible if you give the patient thiamine. And if it's untreated, it can lead to Korsakoff syndrome. And then you have Wernicke's-Korsakoff syndrome, which is chronic anterograde amnesia, loss of the ability to create new memories after the event. So if you have a patient, they're alcoholic, and they've had trouble remembering things, then you would suspect something like Wernicke's-Korsakoff syndrome, right? Especially if they start having confabulation. So if they're unconsciously making up answer when memory fails, or they're making up stories that just doesn't make sense. Impaired recent memory, peripheral neuropathy, this is all part of Wernicke's-Korsakoff syndrome. Alright guys, let's go into cannabis use disorder. So cannabis use disorder includes marijuana, pot, weed, grass. The active ingredient in cannabis use disorder is 9-THC. Basically what it does, it modulates the CB1 and CB2 receptors of the CNS, which inhibit adenylate cyclase. Basically, onset is shorter and it's more powerful. Marijuana is more powerful if you smoke it than if you consume it. And it's most common abuse illegal substance in the US. Intoxication. So how is the patient going to present? Basically, for their behavioral effects, they'll have euphoria. So they'll have intense excitement and happiness, giddiness, psychosis. They may have anxiety, paranoia, delusions. Psychological effects, dry mouth, right? Cotton mouth, conjunctivitis. They're very hungry, so increased appetite, tachycardia, hypotension. And what are the withdrawal symptoms of cannabis use disorder? Irritability, headache, craving, nervousness, insomnia, poor appetite, depressed mood, and resistance. And usually the treatment for withdrawal is supportive. So next one, hallucinogen use disorders. So this includes mushrooms, right? Mescaline, LSD. LSD is the most common hallucinogen. Patho. So what is the pathophysiology? Basically, hallucinogens modulate the serotonergic system, especially the mesolimbic pathway. Okay. And what are the key facts? It does not cause physical dependence or withdrawal, but LSD may cause flashbacks. So they might feel, for example, closer to God. What are some of the intoxication symptoms with hallucinogen use disorder? Is that they'll have perceptual disturbances like illusions, distortions, and hallucinations, depersonalization, paranoia, mood change, tremors, hyperthermia, dilated pupils, and these symptoms tend to last for about 6 to 12 hours. And that's how you can actually tell between the different types of substance use, is whether their pupils are dilated or constricted. The most common one you'll see is dilated. So for example, for hallucinogen, it's dilated pupils. So that's where I usually start reading the question sum, and then if it says anything about dilated or constricted, then I can kind of narrow down my substance use. So for example, for hallucinogen, it's dilated pupils, and treatment is usually supportive care. And if you need to, you can give them a benzo or an antipsychotic if the patient's very agitated and violent. Alright guys, so next one's going to be inhalant use disorders. This is very common in adolescents. Usually it'll be a paint thinner, typewriter corrections, dust repellent. I would see this very common. I'm from Mexico, so I remember some friends in Mexico when I was younger, they would put something in a paper bag and just like smoke it. And now I know what it is, but yeah, it's very, very, very common, especially among adolescents. And basically the pathology is inhaled and absorbed at lungs. It causes perceptual central nervous system disturbances. And usually it tends to cause a negative urine drug screen. So these patients can also overdose on these also. They can have respiratory depression, long-term central nervous system damage. And what will you find in a patient that's intoxicated on your physical exam is that they'll have perceptual disturbance, lethargy, headache, nausea, vomiting, hyperreflexia, muscle weakness, slurred speech, watery red eyes. So this is high yield specifically for inhalant use disorder, watery red eyes and cough. Whenever I read a question and it said watery red eyes and cough, I knew I had to do something, it had to deal with something with an inhalant. And patients that have withdrawal symptoms, they'll usually complain of irritability, diaphoresis, tachycardia, and sleep disturbances. Long-term usage can cause damage to the central nervous system like dementia, impaired memory, epilepsy, liver, kidney, heart, and muscle. And this is true. When I went back and now that I'm older and I've talked to my friends, because we used to play soccer outside in the streets, and the ones that used inhalants from the paper bag, they had severe central nervous system disorders. Their attention span was just not there, and you could tell. So yeah, treatment for this is usually supportive care. And next one, opioid use disorder. So opioid use disorder usually involves oxycodone, hydrocodone, acetaminophen, oxycodone, and acetaminophen, heroin, fentanyl, hydromorphone, opium and meperidine, like Demerol. And what is the pathophysiology? So it's an agonist at the mu opiate receptor, causing analgesia, sedation, and targets the dopaminergic reward system. So the mesolimbic system, right? We just went over this in schizophrenia, which causes cravings and dependence. There's a really, really good documentary that I recommend on Netflix if you haven't had the chance to watch it. It's called The Pharmacist, and it basically talks about the opioid use disorder epidemic, or pandemic, you can say, that has occurred, especially here in the U.S., and how it opened the gateway for a lot of heavy use of drugs, like worse, like morphine and a lot of drugs. So I really, really recommend that documentary for those of you. Usually what I like to do is I study during the day, and then like the last hour, 2 hours of the day, I'll give time to myself so I can stay sane. And so I like to watch stuff depending on what rotation I'm in. So during that rotation, through my psych rotation, I watched that documentary, and it really helped me understand the opiate use disorder epidemic that's occurring in the U.S. and has occurred. So I really, really recommend that. It's called The Pharmacist on Netflix. And basically, key facts. So meperidine, if you take meperidine and you also take an MAO inhibitor, like phenelzine, which, like I said, these MAO inhibitors are usually used in, they're not used as much in the past, but I mean, if you need to, and it's like the last line, they're used for depression, sometimes anxiety. And if you do use these, like phenelzine and meperidine, you can cause something known as serotonin syndrome, which I'll discuss later on. And usually a patient that is on meperidine, they'll have dilation of pupils. So meperidine is also known as Demerol, and a mnemonic here is Demerol dilates pupils. That's how I memorize dilation of pupils. So meperidine, Demerol dilates pupils. So intoxication, how is the patient going to present? They'll have euphoria and sedation, drowsiness, impaired social functioning, impaired memory, slow or slurred speech, and altered mental status. Psychological, pupillary constriction, narcotics, tend to be miotic, respiratory depression, bradycardia, hypotension, coma, nausea, vomiting, hypothermia, and chronic pruritus, constipation. Since the opioid receptors in the GI tract tend to decrease motility, this is why the patient will complain of constipation. Now, if it's withdrawal, it's not life-threatening. Actually, intoxication is more life-threatening than withdrawal. So withdrawal, the patient will usually have psychomotor agitation, anxiety, irritability, twitching, yawning, dysphoria, insomnia, and diaphoresis. Their vitals will be hypothermic, they'll have hypertension, tachycardia, flu-like symptoms like rhinorrhea, myalgias, chills, piloerections, so they'll have like goosebumps, nausea, vomiting, and diarrhea. Everything leaks, so everything is going on, right? Versus when they're intoxicated, they're constipated, it's the complete opposite when they're in withdrawal, is that they're having everything, nausea, vomiting, diarrhea, goosebumps all over them. And also ocular, pupillary dilation and tearing. So that's how you differentiate. So intoxication is going to be constriction, right? For benzodiazepine. Withdrawal, it's going to be dilation. Versus intoxication for other disorders like you have your inhalants, right? It's pupillary dilation. So that's where I usually start. If I start reading a question and I read that their pupils are constricted, then I'm like, And then I start reading that the patient is having constipation and symptoms of opiate use disorder, intoxication, then I'm like, okay, you know what? Constricted, that's going to be opiate use disorder. But if they're having like nausea, vomiting, diarrhea, and then they have dilated pupils, then it's going to be withdrawal, right? Okay, guys. So what is the treatment for withdrawal syndrome? So you want to do something like clonidine, which is an alpha-2 agonist. It can actually suppress your autonomic hyperactivity, right? Because everything's going really, really fast. That's why they're having the nausea, vomiting, and diarrhea. And you can also give NSAIDs for pain. You don't want to give any opiates because this patient's already addicted to opiates. So that's why you want to make sure you give them NSAIDs for pain. Okay, and treatment for opioid overdose is methadone. This is a long-acting synthetic mu-opioid receptor agonist. It's safe in pregnancy. It does not produce withdrawal symptoms, decreases cravings, and it's great for patients with a long history of addiction, like using IV or needing daily structure. Buprenorphine also, which is a partial mu and kappa opioid receptor agonist, and it helps with cravings. And buprenorphine is usually combined with naloxone to create Suboxone. And Suboxone is actually very effective as an opioid partial agonist to help combat cravings and withdrawals. And naloxone, it helps block any reward gained from external use of opiates. That's why Suboxone is usually used a little bit more than buprenorphine, because it's both naloxone and buprenorphine. So the mode of actions work together to have a higher synergistic effect. Suboxone also does not cause any respiratory depression like methadone, and it's a strongly mu receptor. And then you also have naloxone, but naloxone is short-acting. So like I said, naloxone, short-acting, it's used for overdose and emergencies, and naltrexone is usually used later. Okay, so T, later, naltrexone. Naltrexone is a competitive agonist of mu-opioid receptors, and you start this post-withdrawals. Okay, next disorder, sedative and hypnotic use disorder. So this includes benzos, barbiturates, zolpidem, zaleplon, and basically the patho is that benzos, what they do is that they increase chloride channel opening frequency, right? So it's opening them, and this is increasing the amount of GABA. And then barbiturates increase chloride channel opening duration. So that's how you differentiate between both of them, is that benzos is that you have the channels, right, and it's increasing the frequency that they open. So that helps increase your amount of GABA receptors. Versus your barbiturates, they just increase the amount of time that these channels are open. Okay? So benzos, like I said, they increase GABA activity. That's why benzos tend to be used also for alcohol withdrawal treatment, right? Because in alcohol withdrawal, you tend to deplete your GABA receptors, and you want to make sure that you increase those. And that's why you give benzos, because they're increasing the frequency that these channels are opening, so it's helping you move more GABA in, okay? And key facts is that barbiturate withdrawals are actually the deadliest form of drug withdrawals, okay? So make sure that you're very familiar with that. And what are some of the symptoms of intoxication or physical exam findings that you can find in a patient with a sedative or hypnotic use disorder? Is that they'll have disinhibition, offensive behavior, depression, drowsiness, confusion, slurred speech, ataxia, impaired judgment, labile mood, erratic behavior, aggression, psychological effects, hypotension, respiratory depression, right? Because benzodiazepines are known for causing respiratory depression. Coma, incoordination, lateral nystagmus, and chronic effects are Wernicke's encephalopathy, which we went over, which is a triad of ataxia, confusion, and oculomotor palsy. Korsakoff syndrome, which is amnesia. It's both anterograde and retrograde. Hepatomegaly, pulmonary erythema, cirrhosis, Dupuytren's contractures, which is the one with the fingers, right, where you can't really straighten your finger. Gynecomastia, testicular atrophy, increased MCV, so macrocytic anemias. And the treatment for intoxication for benzodiazepines is going to be charcoal and lavage. This is only done if it's 4 to 6 hours, within 4 to 6 hours. So if you have a patient and they ingested benzodiazepines like a day ago, you can't use charcoal and lavage, right? Because you have to use charcoal and lavage within 4 to 6 hours. So you have to make sure this is high yield, 4 to 6 hours. You can also use barbiturates. This helps alkalinize urine with sodium bicarb to promote renal excretions. And basically for benzodiazepines overdose, flumazenil. So flumazenil for benzodiazepine overdose, okay? If it's been within 4 to 6 hours, and you can probably do charcoal and lavage, but benzodiazepine overdose, flumazenil is basically it, okay? All right, guys, for withdrawals. So withdrawals are very, very deadly for benzodiazepines, okay? If it's between 6 to 24 hours, the patient will usually have symptoms of increased central nervous system activity. So they'll have tremors, insomnia, nausea and vomiting, anxiety, tachycardia, hypertension. If it's between 6 to 48 hours, patient will have seizures and hyperreflexia. 2 to 5 days, delirium tremens, which we already discussed in the alcohol use disorder. So basically, alcohol and benzo withdrawal treatment is the same, right? you treat also alcohol and benzo withdrawal with benzodiazepines. And like I said, delirium tremens, they usually have altered sensorium, tactile or visual auditory hallucinations, altered mental status and seizures, coma and death can lead to. And this tends to occur usually when a patient is hospitalized for an unrelated illness. So like I said, treatment is going to be a benzodiazepine taper, exactly the same like alcohol use disorder. So alcohol use disorder, benzodiazepine withdrawal, it's going to be a benzodiazepine. That's interesting, right? Benzodiazepine withdrawal, but you're giving them benzodiazepines. Still, that's the answer. Okay, next one, guys. Stimulant use disorder like cocaine. Okay, what is a pathophysiology? Basically, in cocaine, what it does is it blocks dopamine reuptake from your synaptic clefts. So that's why they get that high feeling, right? They have more dopamine since it's blocking that synaptic cleft. So patients tend to be irritable. They tend to feel grandiose, impulsive. This drug is very popular, as we know, in the clubs and among artists. And cocaine has a longer onset but shorter duration of high and less severe with withdrawals compared to amphetamines. So what are some of the general signs and symptoms? The patient will be complaining of tachycardia, diaphoresis, dilated pupils, euphoria, aggression, and agitation. They'll also have nasal congestion. So this one's like one of the key ones for cocaine. If you see a patient that has dilated pupils and nasal congestion, like the sniffles, and it's cocaine. I know I had a question, like a practice question. It was like a lawyer that he came in and he had like dilated pupils and he was complaining of like he kept like sniffing his nose or sniffling, and it was cocaine. So sniffles, nasal congestion, make sure that cocaine is like in your radar. They can also have chest pain, tactile hallucinations, hyperpyrexia. They can feel paranoid, feelings of persecution, mimics flight or flight response. They can also have cardiac arrhythmias, myocardial infarction even, seizures, respiratory depression, and death. And basically a patient that comes in and they're on cocaine, the first thing that you want to do is do a EKG, right? Because they're more prone to having cardiac arrhythmias. And you also want to do a urine toxicology screen. So treatment, it's going to be seizures. For the seizures, it's going to be something like a benzodiazepine, like lorazepam. For their hypertension and tachycardia, you want to do calcium channel blockers, right? You want to avoid beta blockers. And this also comes into play in tachycardia when you're learning that something's due to cocaine or something's cocaine-induced, like a vasospasm in one of the coronary arteries. Instead of giving a beta blocker, which is something that's commonly given for any type of angina that the patient might be complaining of, you're actually going to give a calcium channel blocker. You want to avoid beta blockers in patients that are complaining of arrhythmias that have cocaine use disorder. And agitation, for agitation, you want to treat with antipsychotics and benzodiazepines. Now, what is the treatment for withdrawal? So withdrawal tends to happen usually within 48 hours after they started using cocaine. And they'll usually be complaining of a dysphoric mood, hypersomnia, being very sleepy, vivid dreams. It's actually a key word, vivid dreams for cocaine withdrawal, increased appetite, fatigue, depression, constricted pupils, right? And treatment for this is usually supportive. You can give them something like bromocriptine to replenish their dopamine, because once again, they've depleted their dopamine, right? And something that is also very common in cocaine and amphetamine abuse is sympathomimetic toxidrome. So this is something really important that you make sure you want to familiarize with, is sympathomimetic toxidrome. And basically with these patients, they'll be complaining of mydriasis, so dilated pupils, diaphoresis, they're sweating a lot, hyperthermia, hypertension, tachycardia, tachypnea, increased bowel sounds. So everything's really, really fast in sympathomimetic toxidrome. And with this, you want to make sure, once again, that you avoid beta blockers, okay? And any patient that is complaining of these symptoms, especially if you want to get the arrhythmia under control. Okay, guys, so the next one's going to be stimulant use disorder, amphetamines. So what is a patho of amphetamines? What do? They block reuptake of dopamine and norepinephrine, okay? And some of the symptoms that they can complain of is euphoria, interpersonal sensitivity, tachycardia, diaphoresis, dilated pupils. It seems like that's the thing, right? Dilated pupils is very common, like I said. It's also very common in cocaine. So that's why you have to make sure that, like when I'm reading the question, okay, it's dilated and it's not constricted. And then, like I said, for cocaine, the patient, they're complaining of nasal congestion, the sniffles. Okay, I think that's cocaine. Versus amphetamines, tachycardia, diaphoresis, increased libido, seizures. And the difference between amphetamine and cocaine intoxication, since like I said, they're very similar, is the duration of high. So for cocaine, it's less than 2 hours, and amphetamines, it's 4 to 6 hours, okay? So differentiate between both of them is that they're both going to present with dilated pupils, okay, when they're intoxicated. And they're also going to present with both of them are going to present with the euphoria. They're also going to present with they may present with the tachycardia and the diaphoresis, like I said, the sympathomimetic toxidrome. But the difference is that, like I said, in cocaine is that the patient may be complaining of sniffles, right, because they snort it. Patient might also have like a perforated septum in cocaine use disorder. Versus amphetamine, they might not have that. Also, like I said, difference between them is the duration of high. For cocaine, it's less than 2 hours, and amphetamine, it's 4 to 6 hours. For patients on overdose on amphetamines, is that they'll have perceptual disturbances, tactile, bugs crawling on their skin, fomication, especially in meth users, excoriation is common due to meth use, hyperthermia, dehydration. Rhabdomyolysis is huge, so make sure you're very familiar that rhabdomyolysis is common in amphetamine use disorder or overdose, causing renal failure. And so what is the excoriation? So excoriation, I put a star next to it. That's usually unique to amphetamine use, so make sure that you have that distinguishing between also cocaine and amphetamine. So amphetamine, usually read a question that they'll have like excoriations between their thumb, their toes, because that's where they usually sometimes use to inject, right? And also for chronic use, for patients with amphetamines, they can have acne, tooth decay. This is huge, and right? They have that meth mouth. And heavy use, they might have psychosis. Sometimes it'll mimic schizophrenia. So that's why when you are evaluating a patient and you're probably not sure if it's something due to meth or something used to drug or schizophrenia, you want to do a drug screen, right? And there's also some designer amphetamines like MDMA, Molly, Rolls, MDEA, also known as Eve. Some of the signs and symptoms of these designer amphetamines is that they'll have a sensation of closeness to other people, dry mouth, palpitations, tachycardia, diaphoresis. Serotonin syndrome is also very common in designer amphetamines, like we discussed. Serotonin syndrome is hyperthermia, clonus, hyperreflexia, agitation, and metabolic acidosis. If, for example, these drugs tend to be combined with SSRIs, so amphetamines and SSRIs tend to cause serotonin syndrome, which was similar with what we talked about with cocaine, right? And for treatment, usually for your use disorder, it's usually supportive. Topiramate can help with the maintenance of sobriety, can help decrease cravings, and agitation and aggression is usually treated with antipsychotics. And I'm sorry, this is going to be for overdose for amphetamines. And stimulant use disorder. That's the next one, like PCP. So PCP, one of my professors had a great way of us remembering is PCP, please call the police, right? Because these patients are extremely aggressive. They're called like Superman because they can just like throw stuff and they're just like extremely aggressive. So PCP, also substance use disorder. Stimulant use disorder also includes angel dust, Sherman's, black dust, Peter Pan, rocket fuel, whack and peace pill. It can be ingested, IV, or intranasally, but intranasally is the most common one. So what's the pathophysiology of these stimulants? They block NMDA receptors, they activate dopaminergic neurons, and some of the signs and symptoms are euphoria, tingling, hypertension, depersonalization, psychosis, myoclonic jerks. And on physical exam, you'll see horizontal or vertical nystagmus. This is actually high yield and key for PCP or for any stimulant, but most commonly PCP, is that they'll have the horizontal and vertical nystagmus. They'll have crazy eyes, so make sure you know that. Hypertension, tachycardia, hyperthermia, ataxia, high pain tolerance. Like I said, they feel like they're Superman. They can keep fighting and fighting, and you can keep beating them, and they're invincible. Numbness, hyperacusis, tactile hallucinations, muscle rigidity, once again, your dilated pupils, amnesia, skin dryness, violent agitation, erythema, delusion, overdose. The patient can have seizures, coma, and death. And usually the treatment for agitation, anxiety is usually like a benzo. And if they're severely agitated and psychotic, you can give them something like Haldol, right? Just shot Haldol and I would see these patients all the time in the ER. Like, they would come in on a weekend at night and they're like punching the nurses and the security guards, and they would just give them a IV shot of Haldol and they're out. All right, guys, next one, tobacco. So tobacco, what is the patho? It's a stimulation of nicotinic receptors in autonomic ganglia. It also acts on dopaminergic reward pathway system. So smoking. It's highest in patients with psychosis and lowest in patients with eating disorder. In pregnancy, it can cause low birth weight, persistent pulmonary hypertension, and intoxication of tobacco. It increases GI motility, tachycardia, insomnia, and anxiety, and withdrawal. Some of the symptoms can include cravings, irritability, anxiety, restlessness, bradycardia, weight gain. And treatment for tobacco, so patients that want to stop smoking, varenicline. I'm sorry guys, I'm really bad with these naming these drugs. Varenicline, basically what's the mode of action of this drug? It's an alpha-4 beta-2 nicotinic cholinergic receptor partial agonist. Well, that's a mouthful. It mimics nicotine and prevents withdrawal symptoms. You can also give something like bupropion, which is something we discussed earlier, right? Bupropion is also used for depression in a patient that you have that has depression and also smokes. You can consider something like bupropion because it helps with smoking. And basically, it's a partial agonist of receptor and inhibits dopamine reuptake, and it reduces withdrawal. So bupropion is also good, like for depression, like I said. And you can also do something like nicotine replacement therapy. So you can do a spray, a gum, an inhaler, or lozenge. My doctor prescribed a lot of the varenicline and bupropion. So now we're done with all the substance abuses disorders, and now we're going to go into somatic disorders. So let's start with somatic syndrome disorders. So the diagnosis. So hypochondriasis plus pain disorder plus somatization disorder. It's basically what a somatic syndrome disorder is. So it's going to be one or more of somatic symptoms that are distressing and significantly disrupt daily life. That's been going on for more than 6 months. Basically, the patient will be complaining of excessive thoughts and behavior. They will have anxiety. They feel like they need to control their life, like doctor shopping. They'll have numerous ED visits and history of unnecessary workups. And it tends to be more common in women. And it's associated with anxiety, major depressive disorder, obsessive compulsive disorder, and potential psychotic disorders. And basically with this question is that you have a patient that's a hypochondriac. They'll also have a pain disorder, like I said, and a somatization disorder. And they will have these symptoms for more than 6 months, okay? And treatment for this is usually a close follow-up with a single provider, because you want to make sure that patient is following up with that provider and they are reassured by the provider, and ensuring that provider keeps up with them and follows up with them and reassures them that they're fine, that they're okay, and to also avoid any invasive procedures, because these patients can be complaining of, for example, abdominal pain, and they are convinced that they have an issue with their abdominal pain and there's something wrong with their stomach, and they are willing to go surgeries for their stomach. So yes. And with this one, guys, I had questions in regards to what it was associated with. So make sure that you're very familiar that somatic syndrome disorders are associated with anxiety, major depressive disorder, obsessive compulsive disorder. I have to say that over again, right? It's common and associated with obsessive compulsive disorder. I had that question actually, and it described the patient with somatic syndrome, and I need to know that what it was associated with. All right, guys, next one is illness anxiety disorder, also known as a hypochondriac, right? These patients are preoccupied with having or acquiring a serious illness with the fear of death. Once again, these have to be going on for more than 6 months. Despite you reassuring them and telling them that they're okay, they feel like they're really sick. Unlike somatic symptom disorder, the distress for the patient is the meaning, the significance, or cause of their symptoms, not the symptoms themselves. So the patient can be preoccupied of having like colon cancer, versus somatic symptom disorders that they can have generalized like abdominal pain or generalized like cardiopulmonary symptoms, etc. Versus illness anxiety, it's a specific illness. I have to say, I think I had this in PA, like I had this like during my didactic year. I swear I had everything. We were learning about a new disease, and I thought I had it. Once I thought I had a DVT, and I went to the doctor, and I was freaking out. And I even freaked him out. He gave me like an ultrasound and everything, and I ended up just having like a vitamin B12 deficiency, which was causing like my neuropathy. And so, and I'm always like that. I learn about a new disease, and I'm like, oh my gosh, I think I might have it. And so, with these patients with illness anxiety disorder, they're very anxious, they're hypervigilant about their personal health status, and perform excessive health-related behaviors like checking their body regularly for signs of disease. Like I said, that sounds like me. And they usually have no somatic symptoms, and they're not reassured by a negative test. And key facts is that usually illness anxiety disorder is related to panic disorder, which makes sense, right? And it's also related to anxiety disorder and obsessive compulsive disorder. And it's usually associated with high levels of impulsive behaviors and trauma. And usually the treatment for this is also reassurance, so just ensuring and telling the patient that they're okay, cognitive behavioral therapy, and close up with one physician once again. So what is conversion disorder? So conversion disorder is also known as la belle indifference, right? So it's French. It's also called functional neurological symptom disorder. So make sure that you know that. I had a lot of questions that I was reading the question. I'm like, this is conversion disorder. And then I keep reading it and it's not on there. And it was functional neurological symptom disorder. So just know that this is also known as that. So what is the diagnosis? How do you diagnose this? Basically, it's the presence of one or more symptoms of altered neurological, motor, or sensory symptoms that cannot be medically explained. So, for example, I saw a movie, and it was a war movie, and there was a soldier that he was complaining that he couldn't see, but his eyes were fine. Like they did an eye exam, and he was perfectly fine, but he kept saying that he couldn't see, and he had just lost one of his best friends. And so this is going to be an example of a conversion disorder. Is basically that something can happen psychologically, and it can affect some part of their movement. Like a woman that may have been raped can say that they can't walk anymore. So things like that, for example. Signs and symptoms: weakness, like I said, paralysis, blindness, like the example I gave, abnormal movements like tremor, gait, speech symptoms that are slurred, anesthesia or sensory loss. Special sensory disturbance, whether it's visual, saying that they can't see anymore, like I said, olfactory, they can't smell anymore, they can't hear, pseudo seizures, and they're not doing it intentionally, versus something like somatic syndrome disorder, they are intentionally doing it. With conversion disorder, it's not something that they're doing intentionally. They are usually very, very calm also. It tends to be associated with mood disorders, dissociative symptoms, and antisocial personality disorders. You want to rule out multiple sclerosis, Guillain-Barré, right, or dementia. And it's very common in women, especially in adolescence, okay, or young adulthood. And with these patients, you just want to reassure them, close follow-up, cognitive behavioral therapy, and hypnosis. Usually with these, with conversion disorder, usually the question that I would read, it'll have a patient that had like some type of trauma, whether they were abused when they were a child, or like I said, the soldier, or whether a significant person or sibling or family member passed away, and then they start having the symptoms. And it's something that you just really can't explain, and it can be really real, like they really can't see. Alright guys, next one is going to be factitious disorder, so Munchausen syndrome. There's been so many movies, so many documentaries on Munchausen syndrome. It's not known as Munchausen syndrome anymore because now we're trying to move away, right, from disease names, from naming patients or naming doctors. So that's why we moved away, and it's called factitious disorder. So diagnosis is intentional falsification or exaggeration of signs and symptoms of medical or psychiatric illness for primary gain. So they are intentionally faking their symptoms because they want to get something out of it, whether it's attention. They like to assume the role of getting sick to gain sympathy. Usually the questions I would read, it was like a nurse that was intentionally making herself ill. I remember a case that I had read. I think it was about the nurse, and she was intentionally making herself ill. She was becoming septic, and doctors didn't understand because they were prescribing her all these antibiotics, and she was an ICU nurse. And she just kept becoming septic and septic and septic, right? And it was E. coli, the primary organism that was causing this for her to become septic. Later, they found that she was intentionally injecting herself with her feces. So that's why she was becoming septic. And she was just an ICU nurse for so many years, and she was responsible for caring for so many patients. Now she wanted to be cared for, and she liked that, having that sympathy. So that's an example of Munchausen syndrome. And patients with factitious disorder have an inner need to be seen as ill, as injured, but not for concrete personal gain. As in, for example, malingering, right? Malingering, for example, if a patient they were working and had a work injury, and they're faking that they're ill so they can keep getting that money from their employer or keep collecting their disability payment. So that's the difference from malingering and factitious. Is that factitious, they're not doing it for personal gain. They want more like sympathy. And the main difference between factitious and somatic symptom disorder is that patients with factitious deliberately fake their symptoms. Okay, so they're faking the symptoms, versus somatic symptom disorder is that something that they really may have going on. Factitious disorder is imposed. So there's different types. There's factitious disorder imposed on self. So it presents themselves as injured, impaired, or ill. So it's a patient doing it to themselves. And then you have factitious disorder imposed on another, or by proxy, which is considered a form of premeditated child or elderly abuse. So basically, someone can be making someone else ill. I don't remember the name of the Hulu show. Maybe those of you who have seen it may be familiar with it. I think it's called The Act. I don't remember. And it's based on a true story. Basically, the mother was making the daughter ill, or was faking her to be ill, so she can gain sympathy. They had free trips, etc. So that's an example of factitious disorder imposed on another by proxy. And this is considered child or elderly abuse. And it's interesting because this is very commonly, and I had a question on this also, seen with women. So it's usually common in women, especially mothers that are doing it to their children. Signs and symptoms: creation or exaggeration of symptoms of illness, may be willing to undergo surgery repeatedly or painful tests in order to obtain sympathy. Like in The Act, they have actually the HBO documentary, which I watched, really good. She underwent so many surgeries, and even doctors don't understand how she was able to get through it, how she was able to get by and get so many surgeries, and how these doctors didn't recognize any of this. So that's why patients are willing to undergo surgery repeatedly or painful tests in order to obtain sympathy. So with treatment, you want to collect collateral information, focus on management rather than cure. Munchausen syndrome is an old term, like I said, that means a severe form of factitious disorder characterized by the predominance of physical symptoms and habitual lying, but it's a factitious disorder. And then we have malingering. So malingering is the intentional production of false or exaggerated physical or psychological symptoms for external incentives for personal gain. Primary goal is secondary gain, whether it's financial, whether it's food, whether it's shelter, and malingering is not a mental illness. So signs and symptoms: they may avoid work, they try to obtain financial incentives, they try to evade criminal prosecution. So a patient, a prisoner may injure themselves constantly, etc. Securing better living conditions, avoiding military conscription. And it tends to be seen in men, especially lower socioeconomic status and history of being in the medical field. Interesting. Versus, like I said, factitious disorder, it tends to be more common in women, and all the other somatic symptom disorders common in women. And dissociative identity disorder. So this is characterized by the presence of more than one distinct personality state. Okay? And it's that's actually key, right? They have more than one distinct personality state. Predominantly develops in victims of significant and chronic childhood trauma, and it's associated with borderline and PTSD. So borderline personality disorder and PTSD. So with this one, with dissociative identity disorder, usually in the question stem, it'll be that they had some type of trauma in their history. And diagnosis is usually done by the disruption of identity manifested as 2 or more distinct personality states dominating at different times. They'll have extensive memory lapses and autobiographical graphical information, daily occurrence, and or traumatic events, and it's not due to substance abuse. Worst prognosis of all dissociative disorders. And treatment is usually psychotherapy. If not, you can give something like SSRIs that target comorbid depressive or PTSD symptoms, prazosin for nightmares, and naltrexone to reduce self-mutilation. So there's actually a lot of movies with dissociative identity disorder. I think one of the ones that I've recently seen was Split. It's a good movie. I think she has more than 10 personalities or 9. Correct me if I'm wrong. It's a male, actually. And it's interesting to see how he goes from different personalities, from a female to a boy to even a huge monster. So that's obviously it's Hollywood take on dissociative identity disorder. But yeah, these patients will usually have more than one distinct personality state. And then you have dissociative amnesia. So that's an ability to recall important autobiographical information, biographical information, so they tend to forget the past, usually after a trauma or a stressful event. So a key fact with this is that they can experience periods of flashbacks, and it's associated with depression and anxiety, but their procedural memory is preserved. So key for dissociative amnesia is that they can't recall their autobiographical information, so they forget their past. And this is usually due to a trauma or a stressful event. Versus dissociative fugue is that they're not aware that they have forgotten anything. It's a sudden unexpected travel away from home with inability to recall one's own identity. They assume a second identity, low anxiety despite confusion. So basically the difference between amnesia and fugue is that amnesia is that they realize they forget something and they're occupied with what they forget, and fugue is that they don't realize they forgot anything and they start their second life. A good example of dissociative fugue is, for those of you who are fans of Breaking Bad, I love Breaking Bad. There is a scene where Walter White walks into a store without pants and he's walking around in underwear and he just stares, and the cops are called, and the next thing you know he's in the hospital. That could be an example of dissociative fugue, right? Because he had a sudden unexpected travel away from home and he couldn't recall his own identity. So another disorder we're going to go over is depersonalization and derealization disorder. So this is characterized by repeated experience of detachment from oneself or surroundings. So basically the question stem will say that the patient is detached from their surroundings, or they don't feel like they're connected to their surroundings. They feel like they have an out-of-body experience. They feel like the world around them as if it were a dream or a movie, so derealization. So depersonalization is experiences of unreality or detachment from one's body, thoughts, feelings, or actions. Derealization is experiences of unreality or detachment from one's surroundings, right? Reality testing remains intact during episode, and severe trauma or stress tend to predispose the patient to having depersonalization or derealization disorder. So as if you can see, most of these disorders that we've gone over tend to have some type of trauma, whether it was in childhood or just growing up or later in adulthood, that has affected them, that has caused this. For example, like I said, conversion disorder. Usually you'll have a patient that is complaining of they can't see, and it's due to maybe they were abused, maybe they were beaten by their significant other, maybe they were in war. And same thing with depersonalization, derealization, and also dissociative identity disorder. They tend to have some type of trauma in their childhood or growing up, or etc. And then treatment for depersonalization is cognitive behavioral therapy and psychotherapy. Alright guys, so now we are going to go with anxiety disorders and personality disorders. Almost done. So anxiety disorders. Let's start with phobia. So what is a phobia? It's an irrational fear of specific objects, places, and the fears are irrational, excessive, and disproportionate. And it's most common mental disorder for women and the second most common for men. Interesting, most of these are common in women, right? except for like something like schizophrenia. But phobia most common in women, and it's an irrational fear of something. For me, I would say my phobia is enclosed spaces. Like I can't do it. I can't. And they were testing us for N95 masks the other day, and they even put like the special the hood over us, and I was like even breathing extremely rapidly, and I thought I was gonna pass out. But yeah, phobia, so something that you're just extremely afraid of. And then there's different types. So you have your social phobia, which is a fear of humiliation or embarrassment in public spaces or being observed by others. So fear of writing, eating, or speaking in front of others. And the treatment for this is SSRIs. Like I said, SSRIs like fluoxetine, paroxetine, sertraline. You can also give propranolol, like beta blockers. It's a beta blocker, and cognitive behavioral therapy. Specific phobias. So specific phobia is a phobia, like I said, a fear of something that is persistent for more than 6 months. It's an intense fear of a specific situation, whether it's heights, flying, objects, or place. And the phobic object or situation is actively avoided or endured with intense fears of or anxiety. Sometimes everyday activities can be impaired by distress or avoidance of the situation or object. Treatment of choice is usually exposure or desensitization therapy, cognitive behavioral therapy, and you can also do a short-term benzodiazepines like lorazepam. And then you have your panic attacks. It's an episode of intense fear or discomfort that develops abruptly and usually peaks within 10 minutes, but lasts less than 60 minutes. And they have to have more than 4 of the following symptoms. So the mnemonic I have for this is DAPANICS. So DAPANICS, DAPANICS. So let's go over these. They have to have 4 or more of these. DAPANICS. D, dizziness, disconnectedness, derealization, depersonalization, palpitations, paresthesias, abdominal distress, okay, that's A, and numbness, nausea, I, intense fear of dying, losing control, like they feel like, basically when you read this question, it's impending doom. That's what I kept seeing in the question is impending doom. Fear of this like impending doom. Chills, chest pain, sweating, shaking, shortness of breath. It's something very severe. My mom actually suffers from, I would say, panic disorder, right? Because she's had multiple panic attacks. So panic attack is basically a single episode, okay? Panic disorder is when they've already had a panic attack. So a panic attack, this is what I'm describing. Yeah, and like she feels like she's gonna pass out, and she feels really anxious. It's really sad to see people that suffer from panic disorder, panic attacks. So the treatment with this is usually benzodiazepines, first line treatment, so you can do something like lorazepam or alprazolam. So panic disorders. So like I said, panic disorder is a recurrent unexpected panic attacks where they've had at least 2 attacks. May or may not be related to a trigger. So a panic attack is a single attack, right? It describes the attack itself. Panic disorder is when they already had a panic attack, specifically when they had more than 2 panic attacks. And they have to have had these symptoms for more than 1 month, okay? And panic attacks tend to be followed by worry about subsequent attacks, so they're very worried that they're going to have another attack. And when I was doing my psych rotation, I saw a lot of patients with this disorder, and it's really sad because sometimes they just cannot function. Like for example, they have fear of losing control, significant change in their behavior, so they avoid whatever triggers them, whether it's passing through a certain area, whether it's doing something specifically. And like I said, they have to have at least 4 of the symptoms of the panics, like I mentioned. So mnemonic DAPANICS. So some of the things that fall under panic disorder is an example of agoraphobia. Agoraphobia, it's an intense anxiety or fear about being in places or situations from which escape may be difficult. So this intense fear tends to occur in more than 2 situations. So whether it's an enclosed space, whether it's bridges, public transportation, basically they're scared of going outside. And it has to be more than 2 settings. And these symptoms have to last for more than 6 months for it to be agoraphobia. It's very common in women. Symptoms tend to occur before the age of 30. And the patho is usually that they have decreased serotonin, GABA, and they have increased norepinephrine. So what is the treatment? You want to start with SSRIs like citalopram, escitalopram, sertraline, first-line treatment. TCAs, second-line, like clomipramine, imipramine, and cognitive behavioral therapy. So if you notice, most of the first-line treatment for most of the disorders like major depressive disorder, anxiety disorder is usually SSRIs. So make sure you're very familiar with your SSRIs. Not just SSRI like the class, but just the names of the drugs that fall within the SSRIs, like citalopram, escitalopram, and sertraline. Okay, next one. It's going to be general anxiety disorder. So general anxiety disorder is due to excessive anxiety or worry a majority of the days for more than 6 months also. And it's not episodic, as seen in panic disorder, situational, like seen in phobias, or focal. So it's associated with 3 or more of the following symptoms, and the mnemonic I have for this one is going to be Macbeth frets constantly regarding illicit scents. So Macbeth frets constantly regarding illicit scents. I memorized this mnemonic and it helped me out through the exam. So Macbeth, what does the M for? Muscle tension. F, fatigability. C, it's going to be concentrating, so difficulty concentrating. R is going to be restlessness. I, irritability. And S is going to be for sleep disturbance. And kids tend to only need one symptom to qualify, because you can actually diagnose a patient with generalized anxiety disorder in children also. And it's more common in females. So onset tend to be in the ages of 20. I have to say I had a classmate with this. She was worried about everything. She was worried about exams. I guess everyone's worried about exams, but she was worried about exams. She was worried about what she was going to do the next day. She was just worried about everything. And this is basically what it is. It's excessive anxiety or worry a majority of the days from 1 to 6 months. And usually the treatment for this, for general anxiety disorder, is antidepressants, like I said, SSRIs, paroxetine, escitalopram. You can also give SNRIs like venlafaxine. Buspirone also stimulates serotonin receptors and blocks dopamine receptors. Buspirone does not cause sedation. But some of the side effects of buspirone are nausea, restless leg syndrome, extrapyramidal side effects, and dizziness. Benzodiazepine also, short-term use only. You don't want to give these for long-term because benzodiazepines are very addictive, right? You can also do beta blockers, tricyclic antidepressants, so TCAs, psychotherapy like cognitive behavioral therapy, but first line is SSRIs. Now, next one's going to be acute stress disorder. It's basically an anxiety symptom immediately following a traumatic event that starts within 1 month of trauma and lasts for a max of 1 month. So if you notice, this is acute stress disorder, right? Versus generalized anxiety disorder was more than 6 months. So acute stress disorder lasts less than 1 month, right? 1 day to 1 month. So trauma tends to occur less than 1 month ago, and symptoms last in 1 month. So it'll be a patient that may be having some symptoms of anxiety, like generalized anxiety disorder, like you're doing your Macbeth friends constantly regarding illicit scents, and you're counting them, and you're like, wow, it might be general anxiety disorder. But then you read, and it's like, okay, but it's in less than 1 month. Then it's going to be acute stress disorder. And treatment for this is cognitive behavioral therapy. Next one's going to be PTSD. So PTSD is exposure to an actual or threatened death, serious death, or sexual violence. Okay? And this can also be due to something that happened to a family member. So it doesn't specifically have to have happened to the individual. It can also have had happened to like their child, to their husband, to their significant other, okay? And this is usually due, the symptoms are more than 1 month after the event, and they can lead to significant distress or impairment in function. So some of the symptoms is that they're re-experiencing it, okay? So more than 1 month, they're having repetitive recollections, like flashbacks, where the person feels or acts as if the event is recurring. The most common one for PTSD is usually a woman that suffered from rape. That's what I kept seeing in the questions, was a rape victim. And usually this leads to psychological distress, avoidance. They persistently avoid anything that is associated with a traumatic event. Negative alterations in cognition and mood, whether it's dissociative amnesia, so inability to remember an important aspect of the event. Negative emotions, persistent exaggerated beliefs, horror, guilt, or anger, or shame. Numbing of responsiveness, limited affect, detachment from others, feeling of unable to feel joy or be happy. Hyperarousal, so this is really big. They're very hypervigilant. They're always on edge. And this is very commonly seen in young adults. And trauma for men tends to include combat experience and urban violence. Like I said, trauma for women is usually an assault or a rape. And also very common in survivors of sexual abuse. So what is the pathophysiology of PTSD? I put stars by this because it's something I got tested on, so make sure you know this. So PTSD, pathophysiology is that they have increased dopamine, so they increased fear in mesolimbic system, increased norepinephrine, so that's why they have the increased arousal. They have increased glutamate, so that's why they have the derealization, increased excitatory and hypervigilance, increased amygdala, hypervigilance, decreased serotonin, so that's why they're depressed. They have increased impulsivity, reduced prefrontal cortex, so they have decreased executive functioning. So the prognosis is that PTSD usually begins within 3 months of trauma. 50% tend to be symptom-free at 3 months. 80% with PTSD tend to have another mental disorder. Okay? So some of the questions I had was, for example, what traumatic events has highest associations with developments of PTSD? Sexual assault, remember? So sexual abuse tends to be very common in PTSD tends to be very common in in sexual assault victims. So what is the treatment? First line is going to be SSRIs, something like a Zoloft, fluoxetine, Paxil, paroxetine, TCAs, tricyclic antidepressants like imipramine. Prazosin is usually given for nightmares, so make sure that you know that. I had questions with patients that were having, especially like patients that went to war, they were having PTSD, and it asks you what was the treatment for their nightmares. Make sure that you know it's prazosin. And imaging. So if you do an imaging, you'll see decreased volume in their hippocampus on MRI. This delays stress extinction, so make sure that you know that. Decreased volume in hippocampus on MRI. And then you can also do cognitive behavioral therapy with these patients. Next one's going to be adjustment disorder. It's an emotional behavioral reaction to an identifiable stressor. For example, the patient just lost their job. They just found out that they have cancer or physical illness. They got divorced, or an event that basically causes a disproportionate response that would develop within 3 months and resolves usually within 6 months after removal of the stressor. Usually, I had a question on this, like of college students that just moved to a new area and they're missing their parents or missing their home. So signs and symptoms: marked distress out of proportion to the severity of stressors, significant impairment in areas of functioning, and treatment is psychotherapy. So the timeline for this one, it develops within 3 months and resolves fully within 6 months. OCD, obsessive compulsive disorder. So patient is aware of obsessions and compulsions and realize that their behaviors are unreasonable or excessive. And it's ego dystonic. So what is ego dystonic and ego syntonic? Ego dystonic is that they're unhappy with how they are. Ego syntonic is that they're happy with the way they are. So obsessive compulsive disorder, right? Because we have obsessive compulsive disorder, obsessive compulsive personality disorder, is that obsessive compulsive disorder, the patient is unhappy with how they are. So they know they have a problem and they want to fix it. Ego dystonic. Make sure you know that. So the obsessions, recurring intrusive or anxiety-provoking thoughts or images or urges that patient try to ignore or suppress. Repetitive behaviors or mental acts, which are compulsions, that the patient feels driven to perform in response to the obsession. These compulsions interfere with their lifestyles. Comorbid with anxiety, depression, and bipolar. So clinical manifestations. So there's different patterns. The most common one is contamination, is that they're constantly cleaning or washing their hands. Also pathological doubt, forgetting to unplug an iron, for example. Symmetry precision, they have to arrange objects in a certain precision. Intrusive obsessive thoughts with or without compulsion also. And treatment for OCD, obsessive compulsive disorder, is an SSRI like Zoloft, Prozac. Typically you want to start them with a higher dose. And then TCAs like clomipramine, that's how I memorized OCD and clomipramine, is that they both have a C, so OCD, C, clomipramine. Cognitive behavioral therapy like exposure and response prevention, and ECT, which is electroconvulsive therapy, is the last result. If you do imaging, you'll see like diffuse frontal hemisphere. And triad of uncontrolled urges, OCD, ADHD, and tic disorder tend to be together, and they tend to be seen in children and adolescents. So, a question, guys. Anxiety disorder is more commonly found in which group? Interestingly, it's more commonly found in higher socioeconomic status. Interesting. Okay, guys, so now we're going to go over personality disorders, my favorite. So, personality disorders. Definition. So they tend to be a wide range of disorders that encompass ingrained and flexible maladaptive patterns of relating to others that cause significant social and functional impairment. What is the criteria? So enduring pattern or behavior that deviates from a person's culture. And the mnemonic is CAPRI, C-A-P-R-I, cognition, affect, interpersonal functioning, and impulse control. Pattern is pervasive and inflexible in different situations and is stable since at least early adulthood, if not before. So there's different clusters. You have your A, B, and C, right? We learned them as weird, wacky, and depressed. So you have your weird, like schizoid. Remember, they like to be alone. Your schizotypal, the people that dress funny or they have like really funny, interesting ideas. And then the paranoid patients. So in cluster A, these patients tend to seem eccentric, peculiar, so unique, or withdrawn. And familial associations tend to be common with psychotic disorders within this cluster. And then we have cluster B, which is wacky. So we'll have the antisocial patients, the borderline personality disorders, the histrionic and narcissistic. And patients tend to seem emotional, dramatic, or inconsistent. And they also have a familial association with mood disorders. And then we have our cluster C, which is depressed and anxious. So avoidant, dependent, and OCPD fall within this cluster. So this patient tend to seem very anxious and fearful. And the treatment of choice usually for all of these is psychotherapy. But let's go into each one, okay? So paranoid personality disorders, the ones that are known as the crazy. Basically, they have a pervasive pattern of distrust and suspiciousness of others. And it's very common in males, and it tends to begin in adulthood. Clinical manifestations, they have distrust and suspiciousness. They tend to misinterpret the actions of others as malevolent. They see hidden messages, are easily insulted. They appear cold and serious, lack of interest in social relationships, and they hold grudges. And they're preoccupied with doubt regarding the loyalty of others. Treatment, like I said, psychotherapy. You can also do some short-term low-dose antipsychotic if severe or benzodiazepines also. So we have schizopersonality disorder, the loner, right? They tend to have a lifelong pattern of being socially withdrawn, and it's voluntarily. They're quiet, unsociable. They have no desire to have a close relationship, and they prefer to be alone. They have to have 4 of the following have to be present. So they have to neither enjoy nor desire a close relationship, choose solitary activities, little interest in sexual activity, anhedonia, few close friends, and take pleasure in few activities. Indifference to praise or criticism, cold, flattened affect. And unlike avoidant personality, patients that are schizoid, they prefer to be alone. Versus avoidant is that they want to be with people they're just scared to. But schizoid is that they prefer to be alone. Treatment is psychotherapy, group therapy, if tolerated, but usually not recommended, right, because these patients like to be alone. And you can also do some antidepressants or low-dose antipsychotics. Schizotypal, which is also part of Class A. It's known as a wizard, right, or the witch, like I said. They tend to have a pervasive pattern of eccentric behavior and peculiar thought patterns, like magical thinking. This can lead to schizophrenia. 5 or more of the following has to be present, so idea of reference. They think that someone's talking to them through the TV. Odd beliefs, unusual perceptual experience, suspiciousness, restricted affect, odd thinking or speech, excessive social anxiety, magical thinking, belief in clairvoyance or telepathy. Some of the questions had that, so belief in clairvoyance or telepathy, bizarre fantasies or preoccupations, belief in superstitions, odd behavior that can include cults or strange practices, and treatment is psychotherapy to develop social skills. And you can also do a low dose of antipsychotics. So let's move on to cluster B. So this is going to be antisocial disorder, also known as a convict. They say that most of these patients that have antisocial disorder are in jail, or the ones that are in prison right now. Basically, they are exploitative of others, and they break rules to meet their own needs. They don't have any empathy. Basically, they're like the sociopaths. That's what they say, right? They have no empathy, no compassion, remorse for their actions. They're impulsive and deceitful, and they often violate the law. They are frequently skilled at reading social cues, and they tend to appear charming and normal to others who meet them for the first time and do not know their history. So you can say like Hannibal or like the famous fictional murderers. You can categorize them as antisocial personality disorder. They have a pattern of disregard for violation of the rights of others since age 15, and they have to be at least 18 years old for this diagnosis, okay? If it's less than 18 years old, then what are they? It's not going to be antisocial personality disorder. And they have to have a history of behavior as a child. Adolescent must be consistent with conduct disorder. So less than 18 is conduct disorder, right? Greater than 18 is going to be antisocial disorder. So you have a patient that's 15 or 14 and they're having symptoms of antisocial disorder. And then the question can ask you, what can this lead to? This can lead to antisocial personality disorder. But if it asks you what are they diagnosed with, it's going to be conduct disorder. I saw this question so many times, so make sure you know the difference between these two. They have to have 3 or more of the following have to be present. They have to be failure to conform to social norms by committing unlawful acts, deceitfulness and repeated lying, manipulating others for personal gain, impulsivity, failure to plan ahead, irritability and aggressiveness, repeated fights or assaults, recklessness and disregard for safety of self or others, irresponsibility or failure to sustain work or honor financial obligations, and lack of remorse for actions. Treatment is dialectical behavioral therapy, so DBT, make sure you know that. So treatment for antisocial personality disorder is DBT, dialectical behavioral therapy. Alright guys, next one is going to be borderline personality disorder. So patients with borderline personality disorder tend to have unstable moods, behavior, and interpersonal relationships. That's key. So usually in a stem of the question, you'll see that they have interpersonal relationship problems. They fear abandonment. Aggression is also very common. They're very impulsive. And they may have repeated suicide attempts or episodes of self-mutilation. It's like my psychiatrist explained it to me. It's either black or white with them. It's like either you're good or you're bad to them. It's nothing in between. They also tend to have repeated suicide attempts or episodes of self-mutilation. They have higher rates of childhood physical, emotional, and sexual abuse than the general population. Criteria is that they have to have at least 5 of the following: frantic efforts to avoid real or imagined abandonment, unstable, intense interpersonal relationship. So they have this extreme love and hate relationship. Usually the relationships tend to be very abusive also. And like I said, they're very dependent also on their significant other. They have a very unstable self-image, impulsivity in at least 2 potential harmful ways. They have an unstable mood or affect, chronic feelings of emptiness, difficulty controlling their anger, transient stress-related paranoid ideation or dissociative symptoms. Usually, like with these patients, I had a question stem that had a patient that went to go see the doctor and they hated the nurse, but they liked the doctor. And they treated the doctor good and then they hated the nurse. And then they asked the doctor for something, the doctor didn't do it, and they hated the doctor and they liked the nurse. So it's like either black or white with them, like I said. And the treatment for them is dialectical behavioral therapy. Second-generation antipsychotics like aripiprazole, Abilify, olanzapine that can help transient psychosis, impulsivity, and topiramate can also help decrease their aggression, but only TCAs are effective. But you want to watch out also for self-harm. So usually dialectical behavioral therapy is the treatment, first-line treatment for these patients with borderline personality disorder. So then we have histrionic personality disorder, the drama queen, right? Some people say that Marilyn Monroe may have had histrionic personality disorder, but no one knows, right? That's how I remember histrionic personality disorder, is that these patients tend to seek attention, or they have this behavior where they're wanting attention from everyone, and they have excessive emotions. They're very dramatic, flamboyant, and extroverted, but they're unable to form long-lasting, meaningful relationships. They're very sexually inappropriate and provocative. It tends to be associated with eating disorders, factitious disorders, attention-seeking, anything that's attention-seeking. And interestingly, like for these patients, usually I had like question stems of like a woman, right, that goes and sees their doctor and they're like unbuttoning their shirt, or they're being very like sexual with the doctor. And so that's an example of also histrionic personality disorder. And they have to have at least 5 of the following: uncomfortable when not the center of attention. So they always have to be the center of attention. They're very attention-seeking. They're inappropriately seductive or provocative behavior, rapidly shifting but with shallow expression of emotion, perceives relationships as more intimate than they actually are. And patients with borderline personality disorder are more likely to suffer from depression, brief psychotic episodes, and to attempt suicide. And histrionic personality disorders tend to be very functional, and treatment for this is cognitive behavioral therapy. And this tends to fall on cluster B. So continuing on to cluster B, we have narcissistic personality disorder. I love myself, for example. They have a sense of superiority, a need for admiration, and lack of empathy. They have a fragile self-esteem. They have a pattern of grandiosity, so they feel like they're superior in comparison to everyone else. So you'll have that question of like the lawyer who goes to the doctor and they don't want to see the doctor. They want to see the head of the doctor. They want the best of the best. So they basically have a pattern of grandiosity, need for admiration, lack of empathy, beginning by early adulthood. Interestingly though, they have a very fragile self-esteem. Even though they act like they are superior to everyone else, they have a very fragile self-esteem. They have to have 5 or more of the following must be present symptoms: preoccupation with fantasies of unlimited money, success, brilliance. They think they're like this intelligent person, this smart person. Requires excessive admiration, envious of others or believes others are envious of him or her. It tends to look like hypomania, but it's not. And the difference between antisocial disorder and this one is in narcissistic is that they both of these patients tend to exploit themselves, but narcissistic personality disorder want status and recognition, while antisocial patients just want material gain. And patients with narcissistic personality disorder tend to become depressed when they don't get the recognition that they think they deserve. And the treatment for this is psychotherapy. So now let's go into cluster C. So we have avoidant personality. Basically the patient's saying like, why don't they like me? These patients have a pervasive pattern of social inhibition and intense fear of rejection. So like I said, in comparison to schizoid and avoidant, is that avoidant, they actually want to be with people. They want a girlfriend, they want friends, but they're just scared to. Versus schizoid is that they're content being alone. They're happy being alone. So they have this fear of rejection. It's so overwhelming that it affects all aspects of their lives. They desire relationships, but are extremely shy and easily injured. Criteria is a pattern of social inhibition, hypersensitivity, and feelings of inadequacy since early adulthood. Symptoms are afraid, that's mnemonic, A-F-R-A-I-D, right? Afraid, avoidant. A, avoids occupation with others. F, fear of embarrassment and criticism. R, reserved unless they are certain they are liked. A, always thinking rejection. I, isolates from relationships. D, distances himself unless certain that they are liked. And treatment for this is psychotherapy, including assertiveness and social skills training, which are the most effective. On cluster C, next one's going to be dependent personality disorder. So these patients are very dependent, like help me, right? They have poor self-confidence and fear of separation. They have excessive need to be taken care of and allow others to make decisions for them. I feel like I'm like that sometimes with my husband. They feel helpless when left alone. Criteria is pattern of excessive need to be taken care of that leads to submissive and clinging behavior. Symptoms. So mnemonic for this is obedient, O-B-E-D-I-E-N-T. O, obsessive about approval. B, bound by others' decisions. E, enterprises are rarely initiated due to their lack of self-confidence. D, difficult to make own decisions. I, invalid feelings while alone. E, engrossed with fears of self-reliance. N, needs to be in a relationship. And T, tentative about decisions. So the key for this is that you want to look for depression and anxiety and regression. So they're going back to a younger age of maturity. And treatment for this is psychotherapy, specifically cognitive behavioral therapy and assertiveness and social skills training. And finally, the last one for cluster C is OCPD, so obsessive compulsive personality disorder. Not obsessive compulsive disorder, obsessive compulsive personality disorder. Basically, my way or the highway. They have a pervasive pattern of perfectionism, inflexibility, and orderliness. So it's basically their way only and only their way. They become so preoccupied with unimportant details they are often unable to complete simple tasks in a timely fashion. They are successful, but they have very poor interpersonal skills. Criteria: pattern of preoccupation with details, rules, lists, and organizations. excessive devotion to work. They will not delegate tasks. So questions I would have is like a patient that is stuck in the office and they're stuck until 12 a.m. doing their work because they don't want to go home because they're the only ones that can get the work done the way it should be done. So that's an example of obsessive compulsive personality disorder. They will not delegate tasks and they will be very rigid and stubborn. OCD, like I said, is ego dystonic. So they're aware that something is wrong with them and they want to change. Versus OCPD, which is what I'm discussing right now, obsessive compulsive personality disorder, is ego syntonic, which is that they're content with the way they are. They don't think there's anything wrong with them. So that's how you want to differentiate between both of them. And this is a high yield, okay, for the PA exam, for your end of rotation exam, is that OCPD is ego syntonic, OCD is ego dystonic, okay? And SSRIs tend to sometimes decrease intrusive thoughts associated with OCD, but usually the treatment is psychotherapy. So group therapy or cognitive behavioral therapy. All right, guys, so let's go into ADHD and autism. ADHD. So ADHD is characterized by persistent inattention, hyperactivity, and impulsivity. And it's inconsistent with the patient's developmental stage. There's two types. There's three types. There's inattentive, the hyperactive, or they're combined. So the criteria is that they have to have the six inattentive symptoms. So fails to give close attention to details or makes careless mistakes, has difficulty sustaining attention, does not appear to listen, struggles to follow through on instructions, has difficulty with organization, avoids or dislikes tasks requiring a lot of thinking, loses things, is easily distracted, is forgetful in daily activities. So these are inattentive symptoms. Hyperactivity symptoms, 6 of them. Fidgets with their hands or feet or squirms in their chair. I feel like I have that because I keep moving my chair back and forth this entire time when I've been doing this video. Has difficulty remaining seated, runs about or climbs excessively in childhood, extreme restlessness in adults, difficulty engaging in activities quietly, acts as if driven by a motor. Basically nonstop. They talk a lot, blurts out answers before questions have been completed, difficulty waiting or taking turns, interrupts or intrudes upon others. So these symptoms have to be longer, going on for more than 6 months, and they have to be present in 2 settings, okay? 2 or more. So whether it's in school or at home. So it has to be more than 2, not only school, but also school and home. Symptoms tend to interfere with their social and academic and occupational functioning. And the onset is before the age of 12. This is for ADHD. So key facts is that females tend to present more with the inattentive symptoms of ADHD versus males, it tends to be more the hyperactivity symptoms. Okay? And comorbidities is that usually substance use disorder also with these patients have ADHD, like nicotine, cannabis, alcohol, depression, iron deficiency, anemia, and anxiety. So the pathophysiology, make sure you know this because I had a question about this also. They have decreased GABA. This leads to their increased activity and decreased ability to concentrate. It can resemble mania. And absent seizures can also be a differential diagnosis for ADHD. So first-line treatment is going to be stimulants. So something like methylphenidate, also known as Ritalin or Concerta. This blocks dopamine and norepinephrine reuptake, and side effects are nausea, low appetite, increased heart rate and blood pressure, stunted growth. Concerta is long-acting and Ritalin is short-acting. But usually for the questions I had, make sure that you're familiar with methylphenidate. It's first-line treatment for ADHD. And the symptoms for sure that they have is low appetite. I remember my doctor prescribed this medication a lot, and the patients always complained of decreased appetite and body weight, that they lost weight. And that's why we made sure that for every patient that we saw in the clinic, we weighed them to make sure that we were tracking their weight, whether they lost weight or they gained weight, because even certain antipsychotics will make you gain weight. And also dextroamphetamine, which is short-acting. You can also give lisdexamphetamine, which is also known as Vyvanse. My doctor gave this a lot out like candy. It's an inactive metabolite of dextroamphetamine. Amphetamine salt also, like Adderall. This blocks dopamine and norepinephrine and stimulates continuous release. Short-acting, but some of the side effects are nausea, low appetite, increased heart rate, and blood pressure, stunted growth. So once again, first line is going to be stimulants, specifically methylphenidate. Second line is going to be non-stimulants like atomoxetine, Soterra. This is a norepinephrine reuptake inhibitor. Side effects are decreased appetite, insomnia, dry mouth. So if you notice, most of these drugs for ADHD have decreased appetite. And just make sure that you are familiar that if you have a question and the patient has ADHD and is stating that the mom doesn't want any stimulant, then what can you prescribe? Because methylphenidate, which is first line, is a stimulant, right? Well, you can prescribe atomoxetine, which is a non-stimulant. Okay, so just make sure that you are familiar with that. You can also give something like alpha-2 agonists like clonidine and guanfacine. This tends to be used first line if stimulants are not tolerated. And they also tend to reduce peripheral symptoms. Side effects, since it's an alpha agonist, right? You'll have things like decreased blood pressure, so hypotension, sedation. And then also, you can also give antidepressants like SNRIs, CCAs, MAOIs, but they're usually as an adjunct therapy. All right, guys, so autism spectrum disorder. So with autism, it's characterized by impairment in social communication and interaction and restrictive repetitive behaviors or interests. So that's key, is that they have these repetitive behaviors. They have problems with social interaction and communication and ability to hold conversation, decreased eye contact, so they can't maintain that eye contact with you, lack of interest in peers, lack of reciprocity, lack of social cue, restricted repetitive patterns of behavior, interests, and activities, preoccupation with unusual objects, increased total brain volume. So basically with these patients, with the questions that you'll have is that you'll have that patient that is just placing blocks in a certain pattern and they're not talking, or that patient that has not talked for autism, or they just don't associate or talk to their friends or their siblings, or just don't talk at all. So this is usually how an autistic patient will present. So autism tends to encompass a lot of disorders like Asperger's, childhood disintegrative disorder. So childhood disintegrative disorder is a normal development until 2 years of age, and then the loss of verbal, social with autistic-like behavior before 10 years old. Their EEG tends to be abnormal, and they tend to have seizures also. And then you also have Rett disorder, which is very common in girls. It's a cognitive development disorder that basically they have cognitive development that never progresses beyond the first year of life. They have decreased growth in head circumference and development, stereotype hand movements, impaired language and psychomotor retardation, gait abnormalities, and the onset is usually between 5 to 48 months. And then another one, basically, well, for ADHD, for autism, the treatment is basically you want to start with the family, right? You want to educate them about autism. You want to also do behavior therapy to teach them, teach a child basic skills. But treatment, you can give them something like Abilify and Risperidone. This is high yield, guys. So Abilify and Risperidone for autism, irritability, agitation, and impulsivity. So for this one, for questions like these, you'll have a child or a mother that comes in with their child who has autism, and they're complaining that the patient is just really impulsive and agitated, or when they become impulsive and agitated, she's wanting something. What can she give them? And so it would be aripiprazole or Abilify and Risperidone. Okay, so make sure that you're familiar with this for autism. And then you have Asperger's syndrome, right? Social impairment, but they have preserved verbal ability. Usually, most of these individuals have a very high IQ. They have normal language acquisition and cognitive development, and one of the doctors I worked with had Asperger's, and she was so smart, but she did have some social impairments. You can tell she was a little awkward, but she was extremely smart. All right, guys, next one, we're going to go over behavioral and disruptive disorders in children. So we have our oppositional defiant disorder, which is a maladaptive pattern of irritability and anger, defiance, or vindictiveness that causes distress in the patient or the family members, like their mother or their parents or father. And this has to be going on for at least 6 months. They have this hostile and negativity, they're very negative, defiant behavior with at least 4 of the following. So anger, irritable mood, they lose their temper, they're very resentful, argumentative, defiant behavior, they argue with authority, they break rules, they're vindictive, spiteful, at least twice in the past 6 months or blaming others for their mistakes. So keyword for this one is that they're very vindictive for oppositional defiant disorder. Their behavior does not occur due to another mental disorder. Anger is usually deliberate, and it's usually towards an authority figure, whether it's a parent or a teacher, and it tends to be associated with substance use disorder, mood disorder, ADHD, and nearly 60% of patients with ADHD have oppositional defiant disorder. So make sure that you know this. So nearly 60% of ADHD kids have oppositional defiant disorder, and oppositional defiant disorder is related and associated with substance use disorder and mood disorders. Okay? Treatment is family therapy, cognitive behavioral therapy, and sometimes you can do stimulants and atomoxetine. I actually put a star by this because I think I had a question on this in regards to the treatment for oppositional defiant disorder. You want to also make sure that it's family therapy. You'll have a question with cognitive behavioral therapy, motivational therapy, all these other therapies. It's family therapy for oppositional defiant disorder. Next one's going to be conduct disorder. So remember we had just discussed antisocial disorder. Now, conduct disorder, they have to be younger than 18 years old, right? So it's a very serious disruptive behaviors where they violate the rights of other humans and animals. So it'll be a child that is like mutilating animals or hurting their dogs or their cats. They like to inflict cruelty and harm through physical and sexual violence. They lack remorse and lack empathy. Criteria is that they have aggression to people and animals, destruction of property, deceitfulness or theft, serious violations of rules, like they run away from home at least once. They're often truant from school before 13 years old. And this one also has a high incidence of comorbidity with ADHD and oppositional defiant disorder. So make sure that you know that also what it's related with. It's associated with substance use disorder and bipolar. And this can also progress to antisocial personality disorder at age 18. So this is high yield, guys. So like I said, greater than 18 and they're having the symptoms, it's antisocial personality disorder. Less than 18, it's going to be conduct disorder, okay? So make sure that you know that. Treatment is usually cognitive behavioral therapy, and key is that you want to remove them from the environment, okay? So this is key. I had so many questions on the treatment. Of course, cognitive behavioral therapy, removed from environment. What was oppositional defiant disorder, the treatment for that? That was family therapy, right? For conduct disorder, it's cognitive behavioral therapy, specifically removing the patient, the individual, the child, the adolescent from their environment. So disruptive mood dysregulation disorder, this is another one. It is a severe recurrent temper outburst that is both verbal or physical at home, school, and social situations. In between the outbursts, the person remains persistently irritable and angry. So they're very irritable and angry in between the outbursts. And they tend to have an average of 3 or more outbursts per week for the past 12 months. Onset tends to be between the ages of 6 to 10. And it cannot be diagnosed after the age of 18, okay? Unlike ODD, so unlike oppositional defiant disorder or conduct disorder, the anger is not premeditated or volitional, so they don't have an intent of causing harm to anyone else, and they're actually remorseful for their actions. Okay, this is disruptive mood dysregulation disorder. Treatment is cognitive behavioral therapy. You can also give them SSRIs. If it asks you for the pharmacotherapy, it would be something like fluoxetine. You can give them something like Abilify, Rapiprazole, and Risperidone for their irritability and impulsivity. And if it's refractory, you can give them something like topiramate or divalproex. Next one's going to be intermittent explosive disorder. It's an extreme episodic anger to the point of being violent, rageful, episodes of anger and violence. Criteria is that they need verbal or physical aggression at least twice weekly for 3 months, which is the same, right? Was similar to disruptive mood dysregulation disorder. But an intermittent explosive disorder, they have to have also or 3 assaultive episodes in the past 12 months with age of onset more than 6 years old. And anger is not premeditated once again, and it's random, but it's very severe. Compared to disruptive mood dysregulation disorder, intermittent explosive disorder, the child is normal without irritability and anger in between episodes, okay? Versus disruptive mood dysregulation disorder, in between the outbursts, the person remains persistently irritable and angry. Versus an intermittent explosive disorder is that they're normal, so they're not irritable between episodes. And similar to disruptive mood dysregulation disorder, intermittent explosive disorder, Anger is not premeditated, and the child will show remorse. Treatment is cognitive behavioral therapy, SSRIs, like fluoxetine, risperidone, and Abilify. And then you have tic disorders. Right? Multiple motor tics, more than one vocal tics to diagnose it. Diagnosis is usually before the age of 18. Onset is usually at age 7 years, greater than 7. It comes and goes, and the tics tend to occur in bouts. Time frame at least 1 year since their first tic episode. It tends to be associated with ADHD, OCD, and anxiety. They have impaired regulation of dopamine in the caudate nucleus. Treatment is clonidine or guanfacine. So this is first-line treatment, okay? Clonidine or guanfacine. You can also do atypical antipsychotics like risperidone, and stimulants tend to exacerbate Tourette's. So you want to make sure that you stay away from these. Okay. Eating disorders. So we're going to go now into anorexia nervosa. It's persistent refusal to maintain a minimally normal body weight for more than 3 months. Severity is usually categorized by their BMI. So if it's mild, their BMI is more than 17, moderate is 16, severe is 15, and extreme is less than 15. Criteria is that they have an intense fear of gaining weight and being fat. They have distorted body image, disproportionate value placed on weight, serious consciousness about weight. Types are restrictive, often with OCPD. So it's interesting because anorexia is associated with obsessive-compulsive personality disorder. Also, the different types can be binge eating and purging. So they eat in binges, self-induced vomiting, they're using laxatives, and they use excessive exercise. So don't only think that anorexia nervosa is only restrictive, meaning that they don't eat. There's also binge eating and purging type, like I said. And I got this question wrong because I kept thinking it was bulimia. So make sure that you know the difference between the restrictive and their binge eating and purging type, where they eat in binges, they self-induce vomiting, they use laxatives and excessive exercise because they think that they are overweight. And the difference between a patient that has anorexia and the type is binge eating and purging versus bulimia nervosa is that usually in bulimia nervosa the patient may have a normal BMI, and in anorexia nervosa their BMI will be decreased, and that's how you can tell kind of the difference between both of them. Physical exam, they'll have cold intolerance, hypothermia, hypotension, right, bradycardia, because they're not feeding themselves. They don't have any electrolytes, any food in their body, anything. Arrhythmias, the most common one is a prolonged QTC. They can also have acute coronary syndrome, cardiomyopathy, mitral valve prolapse, lanugo, right, which is like the baby hair that you can see, alopecia, edema, dehydration, seizures, osteoporosis, which is irreversible, constipation, parotid gland enlargement because they're purging so much, dental caries, amenorrhea, osteoporosis, like I said, which is irreversible. They can also have hyponatremia for the labs, so make sure you know their labs. So hyponatremia, hypokalemia, right? This is why they're very prone to getting the arrhythmias, okay? Decreased LH and FSH, so the luteinizing hormone, the follicular stimulating hormone, this is why they're having their amenorrhea. Decreased T3, transaminitis, decreased estrogen and testosterone, and decreased CR, okay? Decreased CR. Hypercholesterolemia, which I thought was really interesting, but yes, anorexia nervosa is associated with hypercholesterolemia, and you measure the severity based on albumin. So treatment, food. You want to give them food. Your initial goal is to correct their nutritional deficiencies. So if it asks you what is the best next initial treatment, it's going to be correct their nutritional deficiencies, because like I said, these patients are hypokalemic, hyponatremic. They're more prone to getting arrhythmias, and we want to make sure you want to avoid those arrhythmias, right? You also want to do family and behavioral therapy. You can do olanzapine, which is like your last resort. Olanzapine actually helps the patients gain weight. And you want to hospitalize a patient if their heart rate is less than 45 to 50. So that's like severe bradycardia, right? Bradycardia is anything less than 60 beats per minute. So less than 45 to 50, that is red flag for hospitalization. If they have their systolic blood pressure less than 90, orthostatic hypotension, if their temperature is less than 35 degrees Celsius or less than 96 degrees Fahrenheit, if their BMI is less than 15, like I said, that's considered severe anorexia. If their potassium is less than 3.2, okay, you want to avoid those arrhythmias that are well known with potassium, right, hypokalemia, and if their QTC is prolonged, okay? So now we're going to go into bulimia nervosa. So bulimia nervosa, it involves binge eating with compensatory behaviors to counteract weight gain. This can be either vomiting, laxative, use of medications like diuretics, but like I said, the difference between bulimia and anorexia nervosa, where they have the binge eating type, is that in bulimia they have a normal or sometimes overweight BMI, okay? Versus anorexia, they'll have a decreased BMI. So there's a purging type, which is vomiting, enema, they use diuretics, a non-purging type, which is periods of excessive exercise, fasting, after binge eating, and they're ego-dystonic, okay? So they're more likely to seek help, versus anorexia is ego-syntonic. So remember, ego-syntonic is that they're content with the way they are, they don't think there's anything wrong with them. Ego-dystonic is that they know there's something wrong with it and they want to change. So this is why bulimia is ego-dystonic and anorexia is ego-syntonic. And criteria is that they have recurrent binge eating with inappropriate compensatory behaviors more than once per week and more than 3 months. They have comorbid, it's usually comorbidity with borderline personality disorder also. Physical exam, you'll see dental caries, tooth erosion, excessive enamel breakdown, sialidinosis, which is swollen parotid gland from vomiting, right? They have the Russell sign, so that's big guys. Make sure you know that. They might show you a photo of the Russell sign, which is calluses or abrasions on the dorsum of the hand, right? Like right here, you'll see it. You can actually Google a photo, and that's called Russell sign because they're putting their fingers in the back of the throat and they're vomiting, and that acid in their stomach is creating that. Also, they can have petechiae, peripheral edema, aspiration. In their labs, they're going to be hypochloremic and also hypokalemic and metabolic alkalosis. So metabolic alkalosis is vomiting, right? Metabolic acidosis is diarrhea. So hypochloremic, hypokalemic, metabolic alkalosis. And if they're abusing laxatives, like I said, that's diarrhea, it's going to be metabolic acidosis. So I saw these questions so commonly. It asked you what were the labs on this patient, and you need to know if it was a bulimic patient that was not using laxatives and they were vomiting, metabolic alkalosis. A patient that's bulimic and they're using laxatives, it's going to be metabolic acidosis. And their labs, it's going to be hypernatremia, increased BUN, which is their blood urea nitrogen, and increased amylase, right? Because they are vomiting, they have that swollen parotid gland. Treatment is fluoxetine. Interestingly, for bulimia, you can actually use an SSRI to treat, versus anorexia, you can't. So with bulimia, you can do fluoxetine and cognitive behavioral therapy. Make sure you know this, fluoxetine, cognitive behavioral therapy for bulimia nervosa. You want to avoid bupropion. This is important. You want to avoid bupropion in both anorexia and bulimia because it has an increased seizure threshold, right? So it can cause you to have seizures. And in these patients that have bulimia and anorexia, their electrolytes are like all over the place. They're decreased or they're increased. And so if you take bupropion, it's just going to mess that up even more and it increases your threshold of having seizures. So you want to avoid bupropion. Alright guys, so binge eating disorder. We're almost done. Criteria: binge eating more than 2 days for a week for more than 6 months. Treatment: you want to give stimulants like phentermine, amphetamine. This will help suppress your appetite. Topiramate and zonisamide. You can also do orlistat, which helps them decrease their fat absorbed in the GI tract. So the difference between binge eating disorder and bulimia nervosa is that you can have also binge eating, right? And bulimia is that in bulimia is that they are preoccupied with their weight, versus binge eating is that they're not really. They'll eat and they can be extremely overweight. They don't care about their weight, or they don't feel like they have to compensate for what they ate. That's a difference. All right, guys, next one, last one, sexual and paraphilic disorders. So we have sexual dysfunction, which is defined as sexual dysfunction that includes female interest and arousal disorder, and male hypoactive sexual desire disorder. Most common sexual problem reported in females, okay? The female tends to report a lack of sexual interest, lubrication difficulties, especially in females that are past the menopause age, anorgasmia, so they can't achieve an orgasm, which is the most common symptom a patient will complain of in sexual dysfunction. Dyspareunia, so painful sexual intercourse. What is the most common sexual problem reported in males? It's going to be erectile dysfunction, right? But they can also have anorgasmia, lack of sexual desire, early ejaculation, and the time criteria is 6 months. So once again, patients have to have had these symptoms for more than 6 months. So female sexual arousal disorder. So for 6 months, they have to lack the following. They have to have an absent or reduced interest in sex, absent or reduced sexual thoughts or fantasies, no or reduced initiation of sex, no sexual excitement during sex, or no sexual response to cues. Male sexual arousal disorder, also for 6 months, deficient with sexual or erotic thoughts, fantasies, and desire for sexual activity. And the patient can also be complaining of premature ejaculation within 1 minute for 6 months once again. And the treatment is SSRIs like fluoxetine, citalopram. SSRIs tend to prolong the time from stimulation to orgasm, so it allows them to have an orgasm. Next one are going to be the paraphilias. These are fun. It's in the sexual activity preferences that are often deviated from societal norms. So it's a sexual practice that is not considered normal. Paraphilic is usually distressing behavior also. So paraphilia is something that they are content with, and paraphilic is something that they're uncontent. So it's a distressing behavior that they have. Criteria, a disorder requires that the patient has recurrent and intense sexual arousal from the object or thing of interest. The person has acted on these urges, and these urges have significant distress. And yes, it's more than 6 months again for the time frame. It seems like all these sexual disorders are more than 6 months. And it's associated with childhood abuse, emotional, but usually physical or sexual. It's also associated with substance use disorder. It's associated with conduct and antisocial personality disorder also. So there's different types. There's your exhibitionist, which is a sexual desire from exposing one's genitals to unsuspecting persons. So people that, they're the coats, and they get off of showing their genitals to other people. There's also fetichistic disorder, which is aroused by non-living objects like body parts, shoes. Transvestic disorders, which is heterosexual males who get pleasure from wearing female clothing. Fracturistic disorders, which is aroused by touching or rubbing against another person. Pedophilic disorders, which is aroused by sexual activity with prepubescent persons younger than the age of 13. You also have sexual masochism disorder, which is aroused by the desire to receive pain or humiliation. Sexual sadism, on the other hand, is that they are aroused by delivering pain and or humiliation to others. I just memorize them like sadism, like something bad, so they like to give, versus masochism is like they like to receive it. Voyeuristic, which is also known as a peeping Tom, right? They get aroused by observing people engaging in sexual activities or being naked. Treatment for this is usually cognitive behavioral therapy, sensitization therapy, and testosterone-lowering drugs like leuprolide. And like I said, paraphilia, you have paraphilia, which is usually they don't think anything's wrong with them, and then paraphilic, which is a distressing behavior that they know there's something wrong with them and they want to change it. Alright guys, so that is it. I'm actually going to make another video separately since I think this is extremely long. It'll be going over the medications for psychiatry. That was a huge part of the exam, and it's really important that you know that, okay? So medications for psychiatry, like your SSRIs, the classes, the side effects, your benzodiazepines, your first generation, second generation antipsychotics. So I'll go over this in another video. Alright guys, so I hope this video was helpful for you guys. I know it's a little long. Usually what I would do is that whenever I would cook or when I would drive, most of the videos I would listen to, I just let them play, and that's how I listen to them, and they help me out. So repetition is the key. If you can, if you have free time, whether you're working out, you're going on a run, I really recommend, or even driving if you can, listen to these videos. Alright guys, I hope you guys enjoyed this video. If you guys like this video and you guys want me to make more videos similar to this, make sure you give me a thumbs up or a comment below, and I'll talk to you guys later.